Should we leave it without the video?
Hello.
Turn it on. Good morning. We're about to get started. All right. Well, good morning, everybody. Thank you all so much for being here. My name is Dr. James Economopoulos. You can call me Dr. I, and I'm the Tex-CHIP program coordinator. And today we're going to be talking about suicide assessment. And for this first hour, we have a panel discussion. And I'll go ahead and in a little bit, I'll have the panelists introduce themselves. So from 9 to 10, we'll have a panel discussion. And then from 10:15 till about 1, we're going to be talking about suicide assessment. And then we have a video virtual simulation activity for the Tex-CHIP students from 1 to 2. And so we're really excited, and we hope that you all enjoy this training. And so I'll go ahead and I'll let the panelists go ahead and introduce themselves.
Good morning. My name is Dr. Ana Salazar. My pronouns are she, her. And right now I'm the Associate Director of the University Counseling Center here at Texas A&M University Corpus Christi. I'm an LPC and a board-approved supervisor in the state of Texas.
Thank you. Dr. Madhavada, are you able to hear us okay?
Yes, of course. I'm Dr. Marwada. I have been a psychiatrist practicing in Corpus Christi for over 34 years. I have practiced in every setting. I've been a psychiatrist for 42 years. I'm glad to be a panelist for the CHIP programs so far. I think this is my third program. Good morning to everybody.
Good morning. Thank you. Sure. So we're going to go ahead and get started, and we're going to read our little case vignette.
Okay, we actually have two. We actually have two vignettes. Is that how you say it? I hope I'm saying that right. And so they're going to be smaller cases, and then all the questions following will be pertaining to both. Okay, so we'll start with this one. So we're going to call this client CC. Is a 19-year-old female of Native American descent, assessed in the ER following treatment to close 2 deep lacerations on both forearms. They require 28 stitches to close, but did not involve tendon damage. Blood alcohol level is normal, and the woman denies any drug use. When asked, she refers to her suicide attempt as a mistake and a stupid stunt, and denies further suicidal intent or any past history of attempts. She says that it was a stupid thing to do. He's not worth it. She stated referring to her boyfriend and the fight that precipitated the suicide attempt. She relates that the attempt was impulsive and happened after her boyfriend stormed out of their apartment during a fight. Following cutting herself, she immediately called her friend, who rushed her to the hospital. She denies any mood or vegetative signs of depression, as well as any history of depression. I did it to hurt him, that's all. The client is cooperative in the interview and accompanied by her cousin, who confirms her story. Okay, so also I should have said this in the beginning, so forgive me, but like if any of this is triggering or uncomfortable at any point, you can feel free to step out. And this next one, would you like for me to do the questions, or like, would you like for me just to go straight through both of them and then we can answer the questions like for both clients? Okay. So we're going to refer to this client as client JJ, who is a 33-year-old white male, called crisis the previous night after reportedly ingesting 20 sleeping pills. He says he hung up the phone because he got scared and later induced vomiting and slept through the night. The man called crisis again the following morning, reported ongoing suicidal thoughts, but refusing to give name or location. By tracing the call, local police were able to pick up and detain him for assessment. He reports ongoing feelings of frustration and hopelessness, but states that his overdose was impulsive, not planned, and that he regretted it immediately. He is somewhat reluctant to talk about how often he thinks of suicide. He admits to drinking 10 beers the previous night before, and to drinking some several times a week. He denies use of any other drugs other than marijuana, occasionally with others. Client recently lost job of 3 years, broke up with girlfriend, and is uncertain where he will live. He struggles with chronic pain from an untreated back problem that limits his ability to work. Client has two prior suicide attempts, one at 18 and another 2 years ago. He currently sees a therapist and is involved in a transitions group, though reports he is isolated from his family and has few friends. Now we're going to move on to the questions, and if anyone needs me to move back to the case, please let me know. Okay, so based on the information provided, what diagnoses would you consider with clients CC and JJ? And what would be some symptoms within the case to support diagnosis? And of course, just anything else that you might assess within these cases.
So as a clinician for CC, as a LPC, I would not assign her a diagnosis yet. There is no symptomology present for me to assign anything. I have not done a thorough assessment. I have not seen anything. I would need to do much more thorough assessment just from this vignette here, right? For JJ, there is some provisional things there. There's maybe some substance issues. And I'm thinking this because I'm just not being very clear on how much he's drinking, how much he's using substances. He's also already in treatment with another therapist that's telling me that he's doing something, right? And so I'm not sure if that's depression at this point and substance use or alcohol use disorder or something. I definitely, well, I guess one of the other questions down there is part of the treatment and stuff. I would want to be collaborating with his current therapist to see what diagnosis that they're working from, and then do a further assessment of my own, but I would not be assigning any diagnoses because I don't have enough information.
All right, I'll go ahead and go next. So I would agree with Dr. Salazar. I think it's really important that when we look at case studies like this, they don't give you the full picture, right? And sometimes when clients come in, they also don't give you the full picture. So it's really important that we have thorough assessment going on. And that can include, interviews, that could include administering different measures, interviewing family members if you have the opportunity to do so. I would say that I would be curious to explore further the history of depression and if there's any current depressive symptoms that align with the DSM-5, as well as the history of substance use, and if the substance use aligns with the symptomology present in various substance use disorders in the DSM-5, possibly alcohol use disorder. But you'd have to really justify it by making sure that they meet the criteria, right? And the DSM-5 has some really good assessment tools to do that. And that might take us into the next question, but there's level 1 symptom measures in the DSM-5 where it kind of gives you an overall snapshot about the general symptomology being presented. And that can help you identify where you can look further. So then it takes you to what's called level 2 DSM measures. And those are specific measures for symptomology. So if there's depression, there's a depression measure. If there's anxiety, there's an anxiety measure that you can use to further justify a diagnosis. But for the second individual, JJ, I'd be probably curious to explore and see if they might have presenting symptoms of a depressive disorder or substance use disorder, and same with the first client, CC.
Jimmy, if I may call you like that.
Yes, sir.
Sorry. Do you want me to follow up after each question, or you want me to give everything at the last?
Whatever your preference is, if you would like to chime in on any of the questions, or if you feel more comfortable waiting until the end.
Okay, I will chime in on this question, first one. Yes, of course, we don't have any specific information to come to a specific diagnosis, but we always go with a working diagnosis. And if they came to the hospital, then we have to give a provisional diagnosis, and then later on we can clarify the diagnosis when we receive further information. Now, so nowadays there are a lot of diagnoses that end with NOS, not otherwise specified, which also can mean in colloquial terms, I do not know. That is the diagnosis. But you have a mental thought process starting already as to which direction this presentation is going. And certainly the first one, CC, exhibited some impulsive behavior in response to some acute stress. And based on that, we can further build up on the diagnosis after we receive further information. And in JJ also, we can, given the information so far, again, a provisional diagnosis of, it can be ruled out major depressive disorder or adjustment disorder with depressed mood. It can fall in many categories. So we always have to have a provisional diagnosis or something on which lines we are thinking. And of course, we can think of differential diagnosis and comorbid conditions. There is no apparent comorbidity in the first one, but in the second case, we have a comorbidity as a possible alcohol abuse or dependence, marijuana abuse or dependence, because the information is probably vague, and usually substance abuse information is withheld until somebody else, we get collateral information from family members or friends. So far for this first question.
Okay, thank you. So I'll move on to the second question. And it doesn't have to pertain to a specific diagnosis, but what might be some other formal or informal assessments you might use with these clients?
All right, thank you. So I had mentioned earlier a little bit about like the DSM-5 measures, like the level 1 and level 2 measures. So those would be some that I would use, and say that the hospital discharges the clients and they're referred to counseling. It's different when you're working at a community agency because there might be a standardized uniform measure that they require you to use, right, for assessment for your intake. Whereas in private practice, you might have a little bit more freedom. But when I worked at MHID, which is a local mental health authority, we had to do an intake, which involved 3 hours worth or so of gathering information. So we would do a biopsychosocial assessment where we assess their personal history, medical history, family history, a history of mental health treatment. And you would also get the hospital discharge records that would help inform you about what's going on, what are the presenting issues, what's in their history. And then, you would be interviewing them as well. And you'd be interviewing them based off of the semi-structured, interview on the biopsychosocial. And then we would have some kind of uniform assessment that would also be helpful in determining a level of care. And so for adult services, it was the ANSA, the Adult Needs and Strengths Assessment. For children, it's the CANS assessment, the Child and Adolescent Needs and Strengths Assessment. And so what was great is that there was a particular algorithm that would be coded, and it would determine the level of care for treatment. So it would determine how often they might need to be seen by a medical or mental health professional to help ensure the best treatment and support for them. And so some other ones would include, the Beck inventories. I think that the Beck inventories are great. And then I would continue to assess for suicidality. So I would also administer, just because depending on when they were discharged from the hospital, right? I would administer the Columbia Suicide Severity Rating Scale, the CSSRS. And that is something that we're going to be actually talking about, possibly later today too. So it's a really helpful assessment tool. And it's designed for weekly administration so that you can, check and see how is your client, doing. And in fact, anyone that has a diagnosis of major depressive disorder or any depressive disorder, if you work for a mental health agency, you're required to administer the suicide severity rating scale for each session you have. Because that's just how serious it is, especially for someone who was maybe discharged from a hospital. So my priority would be safety. I want to ensure that they're safe. If they mention that they're continuing to have suicidal ideation very recently, maybe they've even harmed themselves, then you go into a crisis assessment. And that would involve even collaboration with your supervisors. So you want to ensure that you're identifying all the risks and needs and that you're assessing a variety of areas. So I'll pass it on to Dr. Salazar.
Thank you. For CC, I would be a little more informal with my assessment, much more in-depth clinical interview. It seems like she's impulsive, like Dr. Marovada was saying, reactionary to what's going on. So she may not know really why she did that, like just to hurt him, but there's some other stuff in there, right? So I'm gonna wanna just dig in there a little bit more. So a formal assessment in my clinical experience isn't gonna really help me get there. I need to build a lot of rapport and also just identifying that she's Native American. So there's gonna be some cultural need there to just pay attention and be more personable to work with her. For JJ, Dr. I mentioned the Beck inventories. Beck has the Beck suicide inventory, which is good to use when someone has already had suicidal ideations or attempts, because it really breaks down. There's like you answer the first, I think it's 3 or 4, and then you skip down to the other ones depending on what their answers are. So that's another additional tool that you could use along with the other assessments to kind of figure out, because he's already had these thoughts of where they're going and how the intensity is.
That's a very good review, Dr. Salazar. Now we are looking at 2 different settings. In the setting Jimmy mentioned, of course, community mental health centers, where this is an outpatient setting, and we have to get the current status on suicidality. We have to consider several risk factors. And then we have to decide at what level of care this client belongs, like inpatient setting or outpatient setting. Since the patient came to the ER, then it is you have to make a quick decision whether this person needs to be detained, say admitted for more observation and getting more information, or like a 23-hour observation to just get some more information and assess the suicidality and lethality of the attempt and also the intent. So I would rather err on the side of detaining the patient in the hospital setting for at least 23 hours observation, which is allowed under law, and then get more information on what direction we have to take. That's usually how we do the inpatient and outpatient settings.
Thank you. I know we kind of got a little bit into question number 3. But what treatment would you implement with clients CC and JJ? Or what would be some of your recommendations?
So kind of following up on what Dr. Maravara was saying, it kind of depends on the outcome, right? Because they are in two different settings. In the ER, it's going to depend on the disposition from the discharge summary that the psychiatrist and the medical staff are going to say too. There should be a discharge plan when they're released, and that's going to help inform. Or if you're the therapist working in the ER, you're going to be helping to craft that discharge plan. So you're not going to be doing that part of the treatment there, but you're going to be helping to inform. So that might include, do they need to step down to, if they're admitted inpatient, do they need to step down to intensive outpatient? Do they need to go to partial hospitalization program? Do they need to go to therapy for CC? For JJ, it's going to be, are you going to be going back to your regional therapist? Because it says he has a therapist and a transitions group. So really the treatment plan is going to be collaborating with those outside providers, potentially, well, no, not potentially, probably. Some kind of substance program integrated into that as well. Also being mindful of health. What did he do? He induced vomiting. Just checking on health always with substance use as well. Making sure that all that's taken care of, making sure he's got providers. That's going to be more of a wraparound care in the cases that I've worked with. JJ is going to need a lot more care, I think, because he already has some care, but it's not working or not working as well as it could be. In summary.
Thank you.
Thank you. And I just touched upon it as to what treatment would you implement with CC and JJ? At this point, I don't see anything starting yet, but these days of hospital stays being 3 to 5 days, and everybody is in a hurry to assign a diagnosis to satisfy the insurance company and then admit, and then because insurance company questions as to what treatment you are providing for this patient with a provisional diagnosis, which usually they both will be admitted as depressive disorder not otherwise specified. And then the insurance company will ask, what treatment are you going to start? And oftentimes I'm seeing these days, because I'm not doing hospitals anymore, but when we were doing admissions in the hospitals, we were very diligent as to what treatment, when to start, and what all needs to go into that. But these days, it's like they start your antidepressant at a high dose right away because they are under the pressure to discharge the patient in 3 to 5 days. And they want to address this 3 to 5 days period high dose of medication, because that way they can justify themselves not doing any favor to patient or anything like that. So oftentimes they end up coming out with a high dose of antidepressants right off the bat, whether it is a first episode or recurrent episode, without consideration to what all has gone through in terms of treatment so far. So it's really kind of a walking on eggshells, but the main thing is we have to do basic blood work to rule out any medical causes, and then any other diagnosis that could interfere with treatment with medications. Of course, counseling would be the mainstay in both cases, but other treatment has to be determined by getting thorough information, like it has been already alluded to by Jimmy.
Thank you. Yeah, a lot of clients when they're in a crisis situation, I mean, let's kind of think about the definition of a crisis, right? It's like when somebody lacks the ability to cope and deal with a situation that they perceive to be stressful beyond the means of their ability to deal with. And so for some of our cases here, you know, I think with CC, one of the precipitating events was the relationship problems, right? And so relationships are so important to us, and we're all kind of relational beings. And if we find that there's problems in our relationships and we feel like we can't cope with that, it can lead to a crisis for a lot of people. So in a hospital setting, oftentimes they'll have individual and group counseling. And sometimes they'll talk about those things. They'll talk about coping skills. They'll talk about some of the factors or events that often lead people to be hospitalized. And with individual counseling and group, they'll focus on ways that they can regulate their emotions. That'll often include skills training, psychoeducation, maybe even DBT related activities, emotion regulation, distress tolerance, right? Mindfulness activities, as well as cognitive behavioral therapy. And then, say that they get discharged and now they're receiving outpatient counseling services. Evidence-based approaches for helping, reduce the potential for another crisis is important. Safety planning is very important. We're going to talk about safety planning later today too, but with safety planning, we want to ensure that they know about steps to make the environment safe, so that if they ever did anything that got them admitted, or if they did anything to harm themselves, like we want to put away like sharp objects, knives, weapons, make sure that if they're released with medications, that their medications are locked up and stored away, or that they're administered by somebody who supervises them. And so safety planning is very important. Individual and internal coping strategies and external coping strategies. So again, that kind of goes with psychoeducation. They may not know how to regulate their emotions, or they may not know how to deal with potential crisis situations that develop, right? So being able to learn how to, have recreational activities accessible, things that they could do to redirect themselves. Oftentimes in the hospital too, clients will tell me, what was most helpful at the hospital was the good food I ate, and I got to play basketball, or I got to do these arts and crafts activities, and they weren't used to doing that before. That wasn't a part of their lifestyle, or that wasn't a part of their daily activities or weekly activities that they had going on. So incorporating some of that in the safety plan as internal and external strategies is helpful. And then also like talking about, places they can go and things they can do to redirect themselves, and people who they can talk to. That's a part of safety planning, and it's really helpful for them, so that they have something that they can kind of remind themselves of whenever they're in a bad place, who they can talk to, who they can reach out to, and things that they can do, places they can go. And we can go into that further if y'all want, but with cognitive behavioral therapy, the big focus is understanding the relationship between our thoughts, our feelings, and our actions. And with our thoughts are responsible for a lot of the unpleasant emotions that we have. And notice, like how I said with the crisis, somebody perceives that they cannot deal effectively with the events, right? And that it's beyond their ability to manage. And so we would process that. We would explore that in counseling. What are their perceptions of this situation? How is it for them whenever, in this case, let's say with CC, her significant other doesn't, her relationship has problems, right? What are the thoughts there? And then exploring how does that affect her, emotions? How does that affect her behavior? What patterns are there? And then seeing if we can, help her have more appropriate or more healthy means of dealing with stressors. Sort of reprogramming, right? So oftentimes people are kind of hardwired to fall into habits, maladaptive habits and behaviors, cutting, self-harm. I'd want to assess for all that, and then really encourage more positive coping skills, going for a run, calling somebody, right, exercising, and then as well as practicing some of the techniques that they might work on with me in counseling. And so maybe that might be identifying thinking traps, knowing when I'm jumping to conclusions, being able to practice relaxation exercises, deep breathing, progressive muscle relaxation, those kind of things. Finding anything that can help promote healing for this person, as well as build up their self-worth, build up their self-esteem, so that they recognize that their life is so much more valuable than where they might be falling into. So I just wanted to add that.
Thank you. Okay, so our fourth question is, how would you include other professionals to provide treatment in an integrative approach? And what resources would you think might be helpful to each of these clients?
All right, I can talk about this. So, I have a lot of experience collaborating with psychiatrists, and I have great experience with Dr. Motivada. And what I often will do is, when I know that they're scheduled, like in an inpatient setting and an outpatient setting, depending on the outpatient setting, there's high levels of integrated behavioral health care, right? So you might work in the same office with a medical provider, with a psychiatrist. And if I knew that my client is scheduled for a psychiatric appointment, I would make sure that I can free up my schedule to be present there with them. And I would want to ensure that, the nurse and the psychiatrist are aware that, they were recently discharged from the hospital, and these are some of the presenting issues that they're reporting, that these are the medications that they were, prescribed with when they were released from the hospital. And I would inform the psychiatrist, a little bit about what's going on. And I would support the client too beforehand if they have any questions that they'd like to ask the psychiatrist. If there's anything that they'd like to know about, maybe that might be confusing or they might want clarification on when it comes to maybe the role and functions of medications. And I would try to be I would try to mediate that conversation and help the client, be able to speak up and ask those kind of questions. And I'd like to help, clarify any misunderstanding or just clarify, what it is that the psychiatrist, is thinking for treatment as well. And so, yeah, just ensuring that we have good communication, that we're clear in understanding, and that everyone feels that they have the opportunity to, share.
Thanks, Jimmy. I'll follow up on that also. I always believed in multidisciplinary approach, which means involving counselors, nurse, social worker, psychologist, and of course, if there is any medical input, of course, we'd like to do that. 30 years ago, even in hospital settings, we used to have that multidisciplinary approach, meetings every morning, discussing patients, and then focusing on each patient one at a time. In outpatient setting also, as Jimmy has pointed out, I myself used to have assigned caseworker and any therapist, if it is possible, if they have time. Like Jimmy said, he made time to be present. So that helps because patients usually talk differently to a social worker, to a therapist, and to a psychiatrist. They don't talk the same things. They think certain questions have to be answered only for a psychiatrist. Oftentimes it happens like that. Like a caseworker used to be sitting with me all the time, and when I asked the patient, "Hey, how are you doing today?" "Oh, I'm fine. How has it been going?" Good, good." And then the case manager says, "Hey, wait a minute. What did you tell me just now before we came to the office?" "Oh, yeah, that, I lost job and I'm having financial difficulties. I'm doing this." They will pour down 10 to 20 recent stressors. Obviously, they're not going to tell me that they deserve those answers to counselor, social worker. And they give some information to me which they haven't shared with other disciplines. So that's why I always believed in multidisciplinary approach. I still do, but things are not the same now. And case managers find out some reason not to be present, and the administration also supports them, saying that, oh, they have to do this, they have to do this, they have to do this. In the whole month, there may be 3 clinics in that clinic with the psychiatrist, and they can do rest of the work in 27 days. But no, they have to do that only at that time because they don't want to sit with the psychiatrist. So I'm seeing this transition, which I really do not like.
For the people in the room looking at me smile, I used to run the Robstown outpatient clinic. So I've worked with Dr. Marvada before. He might not remember me though, it's been several years. But being able to be the filter in between the client and the psychiatry or the medical professional is helpful and is a tool that I think clients don't understand that they need. In some cases, not all cases, some clients are very good at advocating for themselves and understanding that. But I had a client describe it to me as like, with you as a therapist, right? With you, I can tell you my story, but with the doctor, I just want to tell them my symptoms. But a good psychiatrist knows that the story is the reason why the symptoms, right? And so helping to work in an integrative way, and it's not gossiping, it's helping to inform, right? To make more effective treatment. I'm going to jump into number 5 because it's part of number 4. So number 5 is what suggestions do you have for novice professionals to be mindful of CC and JJ with treating their symptoms, and what are some cultural considerations? Because I was going to answer number 4, but I can't answer number 4 without answering number 5. So for JJ, I was rereading his vignette, and JJ needs some help. So again, reminding of my time when I worked at, what was it called when I worked there? BHC something? Behavioral Health Center in Oasis County. It's been a minute. Yeah, he's at risk of homelessness, it looks like. He lost his job. How is he going to afford the care that he might need? He's already in therapy, but is he going to be able to sustain that after whatever emergency services that we're providing him right now? What else does he have wrong? Substance use, chronic pain, medical care is expensive. Chronic pain is difficult to treat. It can be expensive, it can be lengthy, it can be hard to diagnose and assess. Remember, I'm not medical, so we would need to do a lot of referring. He would need to be, and I'm just going off assumptions from a vignette, right? So thinking about what we have here locally, getting him into MHID, getting him into Nueces County Clinic Card Program Services, getting him all of those things together, making sure he's got some housing, some finances lined up. And I'm mentioning all that because as counselors, we want to fix the emotion stuff, right? Like, well, what's wrong? Your emotions and things. Well, you can't if you're homeless, right? So kind of thinking about those needs of, yes, I want to feel better and I can't sleep at night because I don't know where I'm going to live. Right, so kind of some of those things. For cultural considerations for CC, and some resources, because she has, and that's what I'm thinking of, that's where my brain goes automatically, because the first sentence is that she's Native American and she has some family and some support, even though she broke up with her boyfriend. She told her friend who drove her to the hospital, but her cousin's there with her. So that's 2 key pieces of support, right? So I'm going to lean in, and I'm thinking integratively. I'm not going to automatically assume that she's going to need therapy, what we think of therapy. Maybe she needs a healer. Maybe she needs to do some cultural care. By coincidence today, there is the inaugural powwow here on campus. So maybe I might refer her to that. You know, maybe I might refer her to lean into some further into her community, because she has some community connection. She ain't got a boyfriend no more, but she has some community connection, right? Like she's got her cousin and her friend who both care about her. So how can she lean into that? Those are resources that I think novice professionals forget about, because when we think resources, we think therapy, we think medication, we think psychiatry, all of that stuff. But resources can also be the people and the other stuff around you in your life that can help you. JJ doesn't have many resources, so we're gonna have to help develop those resources. And we know nothing, what do we know about JJ culturally? 33-year-old white male. So it might be harder to find out what he can lean into culturally, right? What ties him to his community. He's isolated from his family and has few friends. So help him define what family means for him culturally. Just because he's white doesn't mean he doesn't have a culture. So helping him lean into that and kind of figure out what that might mean for him, and what his identity means for him, because if he's tied to his work and that's what he's lost, then that might be helpful for him to rebuild and to reconnect as he's figuring out, I don't know, all this other stuff. Pain, and JD needs help.
Okay. Yes. Advice for novice professionals is when somebody comes to us with a history of suicidal ideations, suicide attempt, what looks like a suicide attempt, we have to be able to differentiate on all these things. They are a separate entity by itself, and then they all combine, um, including cultural factors or ethnic practices or beliefs. All of those go into this, and one should be knowledgeable in at least some basic idea as to what ethnic backgrounds or what cultural practices people have that differentiate from each other. That's very important because, as the vignettes show, one is Native Indian and other is white American, well, Caucasian male. Now, these are not, we are not going to like um, categorize them in with a bias, but being knowledgeable about what practices are common and what are not associated with the specific culture is very important to know. Now, about the suicidal ideations, suicidal attempt and suicidal intent. Okay. People may have suicidal ideations for 30 years, 40 years. They may not do any attempts, or they may have 20 attempts, 30 attempts, like that. In every case, like first case, like CC, when she cut herself deep enough to have stitches, but not, luckily for her, it didn't hurt, cut the tendons, which would have happened if, she was not lucky. Now, it's certainly an impulsive act. And when you explore the intent, what did you plan on achieving by doing that? That's a question I asked. And oftentimes they say, well, like she said, I want to get back at him, or I didn't realize it is taken like a suicide attempt. Because there are people who are cutters. That's a term used for cutters, which they will have old and new scars on forearms and thighs and things like that. So it all depends on the lethality, the intent, and specific plan. Did they plan this over a period of time, or did they just do it on the spur of a moment? And then you have to go into the past history of what we call as risk factors. The past history will give you a lot of information about the risk factors, like previous suicide attempts is a high risk, single is a high risk. Males are known to complete suicide more often than women who have chronic suicide attempts and cutting, and alcohol or substance abuse is another risk factor, and then age is a risk factor too. So here, both ages are not that old, but the older you're looking at somebody, the risk factor will be higher. And any other extraneous, other stressors like legal problems, marital problems, family discord, and complicating medical conditions. and comorbid substance abuse diagnosis. So these are all the things that what we call as risk factors. And one will be put on a higher risk depending on what you have in terms of past history. And also, we need to get the information about past treatment. Did they receive any medications? How many medications? How many doctors? Were there treatment failures, or they kept changing on their whim and fancy? And then, what kind of counseling did they have? I, for one, always feel that many patients that come to us really need counseling. Not, I explain to them, hey, your problem is not just between you and me. Medication, I prescribe medication, you take it, you report side effects, you report whether it's effective or not. But that's not the whole story. You have to have this. Maybe many psychiatrists don't advocate counseling, but I, for one, really believe in that because many they explain to them what is biological depression, what is circumstantial or situational. Oftentimes, it could be situational depression. Everybody will be depressed at some point or other in their lifetime due to whatever is happening to them. But if it lasts beyond the stress, then it will be considered as a major depressive disorder diagnosis. So we have to get those informations also. So whether crucial factors or the risk factors that we have to consider, and what is their family support? Do they? It's like he says lonely. Um, then do they have friends? So all these things go into that psychosocial and circumstantial and situational factors.
Thank you. And just to follow up briefly about what are other suggestions for novice professionals, I'd say continue to get training, because this is a very important issue here where we have to be prepared for working with clients who struggle with suicide, okay? So get training and assessment. Be able to collaborate with your supervisors and let them know what's going on with your clients. And if your client is in a crisis, call the supervisor up and let them know, because it helps to make collective decisions on that. Be prepared to. I had a situation one time where I was going to see a client. I was driving, and my supervisor calls me and he tells me that I need to go do a crisis assessment for someone else, for another counselor's client, because they weren't able to see them. And so I go to go see them. I didn't have my paperwork with me. I didn't have my crisis assessment forms, right? So I was unprepared, so be prepared for those things. Have your paperwork with you and just kind of know what you need to assess, right? It's most common in crisis forms that you assess their history. Do they have a history of suicidality? Do they have a history of treatment? Do they have a history of hospitalizations? Do they have a history of self-harm? Ideation, are they having current thoughts now? And plan, do they have a plan to harm themselves or kill themselves? Intent, like, are they actually wanting to die now, or what's the intent of it all? Are they wanting to get stress off their back? Are they wanting to escape from some responsibility? And then do they have a means of self-harm? And then safety plan, be prepared for doing safety planning. And other things I'd say, just don't be afraid to ask the tough questions. Don't be afraid to ask, like, are you having thoughts to die or to kill yourself? Are you having suicidal thoughts? When was the last time you've had suicidal thoughts? So don't be afraid to ask those questions. And if you're ever unsure, if you're like, well, I think my client will be safe, that's not a safe place to be. So please ensure that you're following the steps that you need to ensure that your client is safe, which could mean doing a safety plan, which could mean informing a loved one or a caregiver, a parent, somebody about their situation, that you have consent to do so. And I'd say also, make sure that your supervisors are informed, because again, like, if you're having to determine whether they should go to the hospital or not, that that doesn't always have to fall on you. That could fall between you and your supervisor making that, collective decision, professional decision with your client too, of course. And just kind of know the steps to take following that. And then for cultural considerations, yeah, definitely be respectful of your client's culture and be mindful. What are their attitudes? What are their values? What are their beliefs? What are their beliefs about treatment? What are their attitudes towards healing? What does that look like? Does the family make individualistic decisions or do they make collective decisions, right? What do they think about mental health treatment, right? So be aware of that, don't impose your values on your clients, and really work with them, like Dr. Salazar said, who are the people who they want to go to for healing, for growth, for helping, and maybe like with Native American culture, get to know the family, get to know who they reach out to for support. I had a situation where I can remember I was working with a Native American family, and the way that they had family meetings was very unique. I remember going into their home and they had a big circle, and the client of mine was in the center, and they were like the center of the attention there with their family, and they were all kind of talking about her, sort of deciding like some things that they think that she might need help with, right? And that was a very unique experience to me because that was the family's way of kind of like working through family issues. And then at the end of that, her dad gives me a bag of tobacco. And so I was like, whoa, what do I do? Like, this is all so unfamiliar to me, right? And so I took it and then I brought it right to my supervisor and I said, this is what happened. So, just be aware that, and not all Native American families may approach you that way, right? But just consider like their history, their journey, where they come from, and be respectful and be mindful of their practices.
I think that's a great segue into question 6. So in your own profession, what personal example can you share regarding clients with symptoms of SI?
I can, when I saw this last question, I remembered one incident. It happened some 30 years ago. There used to be like a triage, psych triage, and patients used to be brought in by police or voluntary or, in different situations. And when we are on call, we used to go there in person between 10 and 11 o'clock at night to assess whatever warrants that came in and give the disposition. Okay, this goes inpatient, this can go home with follow-up treatment and everything. One night, and then we go there at 5 o'clock in the morning to see any other warrants came between 11 and 5 o'clock in the morning, and we dispose them off, and then we go on our daily work. So one night when I was on call, when I went there at 5 o'clock in the morning and asked the counselor there, how many cases do I need to see? He said there are 2. Okay. And then we could see from the glass and into the room. And unfortunately, all patients that came, women, men, used to be put in the same room. And, there used to be 2 easy chairs to sleep, for the night. And then I asked, okay. Then I looked at that place. There's one man with disheveled appearance, scruffy hair, scruffy beard, and there's a woman sitting there in the chair. And this man was naked and pacing in the room back and forth. I saw her face turn the other side when he's walking towards her. And then when he's going back, then she would turn her head the other side. So her head has been turned. And the counselor said, he has been doing this all night. First he came and then she came. And all night her head was moving side to side, um, nonstop. And he would not stop. Apparently he walked all night. And then counselor asked, he came first, you want to see him, or she came later, you want to see her? I said, I want to see her first. So he brought to the exam room, and I was sitting there and inquired about her suicidal ideations. She just folded her hands and she said, please, 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 please send me home. I just cannot tolerate this. It is so bad, it's very stressful. Now I'm not feeling suicidal anymore. I regret that I said that, and I was brought here and kept here all night, and this is what I have been doing. And I told the counselor, okay, call her family and discharge her home. Okay, the depression, whatever she may have had, is controlled by shock treatment, visual shock. She had to see this naked man face up and down all night. Can you imagine? That I worked better than ECTs, electroshock treatments. This is a visual shock, I would say, that removed her depression, and she was ready to go home. He was, of course, admitted because he is a known schizophrenic for a long time. That's the story I have. You have a lot of lessons to take from that, I believe. Thank you.
Thank you, Dr. Madhavada. Yeah, I'd like to share a story where I was on call and I was asked to do an assessment for a resident at the Juvenile Justice Center. And this resident, he had a history of, kind of saying, oh, I'm suicidal. I want to be, released. I want to go home. But there was something different about him that evening. And so what he was saying to me, it was really scary because he had a history of hospitalization. He had a history of attempts. And you may think, well, he's at the Juvenile Justice Center. He can remain safe, right? How's he going to do anything to hurt himself? He was wearing a smock. A smock, by the way, is like a suit that they wear. It's kind of hard to take off. It's not like regular clothing, but still people can do things to manipulate, that and hurt themselves. And what he had done is he had found a thread on the smock and he had unraveled the thread and he had it ready to try to like wrap around his neck to cut his neck. But he had broke the thread and he's like, well, I was using this, but it didn't work. And I'm like, well, do you feel like you can remain safe? He says, no. I'm like, well, what's your plan? And he said, well, what I'm going to do is I'm going to climb as high as I can on my toilet and I'm going to jump head first to the cement ground. And I thought that's pretty convincing, so he had a plan. He had a means. He had already been hitting his head on the wall. He had cuts and bruises and stuff. And so I said, okay, I think you need to go to the hospital tonight because you've been hurting yourself. You have a history, you have a plan. And when I go and tell the people in the control room, they're like, oh, he's just BSing you. They always come here. They have these counselors come and they pull in your leg, like this is all BS. Like he doesn't need to go anywhere, right? They were really like fighting against me to send him to the hospital. And I said, no, like this is what I'm deciding. So what I'm sharing this because I want you all to realize like you're the mental health professional. You're the one who's trained to assess these things. You're the one to know, the level of risk. And I stood my ground. I said, no, they need to go to the hospital. And the thing is, they didn't want to have to go and call the probation officer to go and come and drive them to the hospital because it was after hours. It was like 11 o'clock at night. So these are the things that happen. You'll have different settings that your clients might be in where the department culture might be different. And maybe they have a negative view of mental health treatment. Maybe they don't believe in what mental health counselors do, or they don't believe in, they don't view your clients the same way. A lot of them, I've had probation officers tell me, these are just kids who break into cars and they're up to no good, right? And so you have to think like, no, these are kids who have trauma, who have, invisible, symptoms sometimes that you don't see, you don't know about. They have, mental health diagnoses, and we needed to help them and to take this seriously. So realize that you're gonna come across opposition. And so I recommended that he go to the hospital, and the hospital is the one who really determines admission. You make the recommendation, you provide the information, you have your assessment tools, but the hospital determines admission, and they admitted him, so there was a good need for him to be at the hospital. And, if I gave in to that kind of, temptation or pressure by people, who knows? He may have hurt himself really badly that night. So I just wanted to share that story.
Well done, Jimmy, holding your ground and recommending hospitalization.
Thank you. I think that's all we got.
They're gonna hear me talk.
I am aware of the time, but if we could spend maybe the next few minutes, if y'all have any questions for our panelists that maybe weren't covered in the case study. Let me go around. That way those online can hear the question. Thank you.
I guess it's kind of pertaining to what you were talking about, Dr. I, just now. Because just recently, actually, I was at one of my sites, and I was dealing with someone who was saying that their adolescent was like, it was like BS, like they're just doing it for attention. So when you're talking to, like, I guess a parent about it, like what verbiage could I use for them to better understand? Like, I'm thinking about the safety of your child, even if like that may be the case, it most likely isn't, but like, how do you deal with that?
For those of y'all online, I'm making the long walk across the room to get to Dr. I and the panelists.
Slide on it though.
Thank you. That's a really great question. It is challenging sometimes to talk to parents, especially if they kind of have their mind made up. And, parents have a lot of their own personal experiences with the child, where they see the child as somebody who may have been defiant for a long time, oppositional. That relationship is severed in a lot of ways. And so they'll just kind of dismiss a lot of the things as, oh, this is just them wanting attention, right? And that's kind of how they just downplay or dismiss a lot of these issues. And so you have to really communicate the seriousness. If you believe that this child is crying out for help, it looks different, right? It's not always them, just saying, I want to hurt myself. They might, cut themselves, or they might, abuse drugs. They might really, lose all hope and care for things. And so you have to let the parents know, that you're observing a serious mental health issue going on, that there's a deterioration in their functioning, and that they're talking about having a plan to hurt themselves. And so, those are things that you have to communicate with the parent. And if they don't like it, which oftentimes is the case, try to respectfully explain to them the seriousness of the matter, and go ahead with your recommendation. And I've been in this situation where I recommend that your child go to the hospital because I don't feel like they can remain safe at home. No, like I'll be there to watch them, or whatever. But if you're not certain that they can still remain safe at home, and if you feel like they'll just run away or something, which they tend to often do a lot of times, recommend hospitalization. And hopefully they'll go, and you can recommend, hey, I can escort you together so we can all go together. And there's other barriers too. A lot of times parents don't want to spend all the hours it takes to wait for the intake at the hospital. Sometimes it could take 3-4 hours. But it's just something that we have to encourage because, we want them to be safe ultimately. And let them know too, like the hospital, they'll come up with a plan following discharge on what we can do and what can be done at home to help, mitigate some of these symptoms and issues. And if they fail to do that, if they neglect to do that, if they don't want to take them to the hospital, of course, talk to your supervisor about that, but it might be something you have to consider, which would be calling Child Protective Services, because it might be medical neglect at that point, especially if you have clear signs that they're a danger to themselves.
So I'm sorry, I'm online, so I can't see like the rest of the room or if anybody's hands are up. But it's kind of along the same lines of the question that Dr. I just answered. But I'm noticing this, I don't know, I guess like trend or, ongoing issue between like a residential treatment center I worked for, and then between cohorts that I'm hearing that are working at integrated sites, like hospital settings, as well as detention centers. I'm noticing this like lack of collaboration, or I guess I shouldn't say lack of collaboration, but like this mindset that the client doesn't, I don't know, isn't taken seriously, or, is just like written off as like a bad kid or a troublesome kid or a troublesome teen. I guess specifically for Dr. I, how do you go about respectfully advocating and speaking up?
Great question. And yeah, so it kind of goes back to Santiago's question too. I was reminded of something. So some places you have resources and some places you may have limited resources. One resource that was at MHID Youth Services was a family partner. Does anybody know what a family partner is? Y'all ever heard of that before? So a family partner is actually a provider who you work alongside with. And in this case, they have been hired because they have their own experience with a child that has mental health needs. And so the family partner has a caseload of parents who they go and they talk to, and they share with the parents, how to better understand their child. They share with them their own personal experiences, their own stressors. So there's a lot of, I hear you, I've been there before, I know this is frustrating, and they help them kind of navigate the whole mental health system. And they have a curriculum, which is a parenting nurturing curriculum, where they educate the parent on parenting skills, nurturing skills, and that really helps, and it goes a long way. And so surrounding that parent with that kind of support is helpful. And I'd say if you're ever in a setting where you're working amongst staff members who might be dismissive or who downplay the seriousness of clients' issues, speak up for the client, advocate, say, while you're not trying to be disrespectful, right? Like I tend to take the approach where I have another perspective I'd like to share. Maybe we can consider this. Let me put something else on the table. This is something that I'm aware of, and this is what they're saying. And this is a concerning thing for me. And then you can support it with, I know other clients in this situation, this ended up causing a crisis, or researchers have found, right? You all are consumers of research now. You've been doing so great in your studies, and you're about to finish and graduate and go out into the world. Share with the world all of what you've acquired. Share with the world all of what you've been studying, what the literature says about risk factors for youth, for adolescents. Those are things parents don't know about. And so psychoeducation, education on that can go a long way, while always maintaining a respectful attitude, right? Also acknowledge the parents too at the same time. Parents, they have their own history, they have their own experience with the child, they have their own expert knowledge with the child, right? So you have to also acknowledge that and respect that. And they're going to be much more likely and willing to listen to you when they feel that they're also heard and understood. Have y'all ever heard that ratio? There's like a ratio where in order for someone to listen to you, they have to be also heard and acknowledged at the same time. So give them that energy, give them that acknowledgement. Draw their strengths into the discussion, make it collaborative too, but don't leave anything out, don't leave anything out. Like share with them your concerns, what you recommend, what you have experienced, the personal things that closely about the child that the parent may not know. Hopefully you can earn the parents' trust in that, so that they can talk to you about those things. Same with the staff members that you might work with. I've been in family team meetings. I've been in department team meetings where people take things very lightly. And so we need to say, hey, like, what's going on here? Like, I'm noticing that, we're starting to laugh, we're starting to mock clients or whatever you might notice, right? Call that out. Or if you don't feel comfortable in doing that, tell someone who's in a leadership role about it so that they can be the ones to address that, right? So because that's so damaging and harmful. That's one of the most damaging things is to work for a department that is critical or dismissive or downplays the seriousness of things. And that spreads, right? That's contagious. And so that might be something you might have to address. Does that kind of help answer your question, Kendall?
Definitely, yeah. Because it's just, it gets, I don't know, the disheartening and like the discouragement has been like kind of building for me, and it sounds like other cohorts that I'm engaging with as well. So, like on one hand, it just sounds like it requires resiliency and continuing this mindset of like being teachable, yes, but also like still being willing to teach others, even though they're maybe in like a different role or, non-mental health role. Like, I can only speak for my specific experience within RTCs, but it was predominantly between like the social worker, family members for sure. But honestly, I was a mental health technician and I spent literally every minute of every day with the kids. Like from the time they got up to making sure they were doing hygiene before bed. And so when we would attend clinical treatment meetings, sometimes even their therapists and the psychiatrists were like, "Oh, but like they're not serious or they're not saying." I'm like, "I spend every day with the kid. How are you going to tell me when you only spend like maybe an hour or so out of the week with them?" So sometimes it's internal between mental health and across multidisciplinary roles as well. But yes, that was very helpful. It was encouraging. Thank you.
Thank you. And I have one more thing I wanted to share too. Sometimes recommending to a supervisor or someone in a leadership role, recommending trainings that should be done. Supervisors should like plan trainings for their staff members. And a lot of these trainings can be related to trauma-informed care or, just things to help raise awareness about how to communicate, how to approach. There's TBRI trainings, trust-based relational interventions. That's often something that's done in juvenile justice centers because, sometimes that departmental culture doesn't have as much empathy for some of these, residents, for youth, so trust-based relational intervention training, so that can go a long way. That can be applicable to all kinds of settings. So I just wanted to add that.
Thank you.
Okay, so just so that we're respectful of Dr. Salazar's time, she's gonna jump into the training in a bit. So we're gonna wrap up questions for this portion. So thank you all for participating. And thank you, Dr. Maruvada, for your time.
Thank you. Have a good one. Bye.
I just want to say thanks to him. Alrighty, so yeah, we're gonna take a 15-minute break and then Dr. Salazar is gonna get prepared for her presentation. And so we'll come back around, I think, 10:35.
Thank you for the reminder because I didn't. All right, so if y'all have not worked with me before, I'm a trainer. I do lots and lots and lots of suicide intervention trainings for the layperson. I'm certified in QPR, question, percent, refer. I'm certified in ASK. I'm certified, I don't even know how many now. Some of them I've let lapse just because I don't use them in the settings that I'm in anymore. Ooh, I just let my QPR lapse. That's all right, doesn't matter. I've trained hundreds and hundreds of people over the past several years. Youth mental health first aid trainer, all of those things, right? So I do a lot of suicide intervention and prevention training in the community and on campus. So one of the things that I do here in my role as an associate director at the counseling center is that every graduating class of teachers who are going out into the field need to have It's mandated by the state to get your teaching certification. We have to train them on suicide intervention. And so that's one of the things that I do. You're nodding, you were a teacher. You were, yeah. So that's one of the things that I do. It's like 50, 60, I think seniors or fifth year seniors graduating, clinical teachers, what they call them. So yeah, I do a lot of training. I'm also an LPCS. This is my 3rd year of being an LPCS. I'm also a site supervisor. So I've trained a lot of people. I'm an educator. I have a counselor education PhD. I'm an advocate. So I do a lot of advocating for my clients when they have needs. I advocate in the field. And I'm also, I don't like to say out loud that I'm a crisis specialist because then they come raining down on me because that's just the way clinical world seems to work for me. But I am a crisis specialist. This is kind of what I do. It's one of the things that I find in my clinical work that does not drain me. Working with individuals with significant personality disorder, that drains me. I get really tired working with that population. Working with little children drains me. That's too much energy. I can't, the systems and families, that drains me. But doing clinical crisis work does not drain me. So I do a lot of crisis work. And I've been doing this for like 12 years now or something, pretty close. This is not liking me. Go. I think the little cute images I had in here are not gonna play. There was a picture of a cute little car to remind people that when we have questions, bring them up. We're gonna cruise along, do what we gotta do, but if we have to park it, we're gonna park the question. Okay. There are 2 things that I say when I'm teaching or when I'm training. And I couldn't figure out, y'all, online how to show your chat box, not cover the screen, all that stuff. So please unmute yourself if you have a question. There's 2 things that I say when I'm training, when I'm teaching, and actually when I'm in the clinical space too. The 2 things that I always say are, I don't lie to people and I don't sugarcoat things. That does me no good, especially in crisis work. So what I'm going to say for this training right now, and I say it all the time, but it is especially true in today's space, is that there is no way you're going to know everything, period, before you leave. There's no way. Absolutely no way you're going to know everything you need to know about suicide assessment intervention before you leave today. I've been doing crisis work for over 10 years, and there's still things that I need to learn about. There's still situations, there's still family things, there's still systems that I haven't navigated. There's still things that I don't know. Who's scared because I said that? It's okay to be scared. Is anybody scared because I said that? A little bit? A little bit? Okay. Who's like, oh, that's fine, I got it.
I saw it more as like I expected.
Yeah. Appreciate that. Okay, so you weren't expecting to learn everything you needed to know.
No, 'cause I'm in like constant state of like
Okay.
you are like
So you were saying that, I'm repeating because people online, you were saying like, you don't know everything, so you're just constantly learning. Love it. I'm here for it. That's the way it should be. Or not should be. That is a positive attitude to have about the situation that we're in because it is always changing. One of the things that I tell a lot of the associates and students that I work with is that we're working with people, we're not building tea kettles. Like, we're not building cars, right? We can't know everything. So I'm going to introduce y'all to the language that I use and why I use it, okay? One of my first suicide intervention trainings that I went to be a trainer, the gentleman who taught us about suicide prevention and intervention was a suicide attempt survivor, right? So he had lived experience. And he had attempted several times, over a dozen, right? And he brought up the language of like, please don't say committed suicide. I didn't commit a sin. I didn't commit a crime. And so I, read some, this is a long time ago, but I started reading research about it and just looking at the different religious factors, or, trauma factors and things. And so I use the language completed suicide, or attempted suicide. Committing does have a negative weight. And so this is the language that I use. Okay. I also always, always, always use very, very straightforward and direct language. I'm not going to sugarcoat things. I'm not going to lie to people about these things. I'm going to be very direct. Do you want to kill yourself? I'm not going to say, do you want to hurt yourself? That same trainer told us, like, he would just tell clinicians all the time, no, I don't want to hurt myself. I'm not going to feel any pain. I'm going to be dead. And so I will say things very, very directly. Do you want to die? Do you feel like being dead? Okay. And I'm just letting y'all know that now. And as an educator and as a supervisor, I tell all of my associates and all my students, this is the language as clinicians that we should have as well. This is the point where we don't need to be, we need to be person-centered in that we care, we're empathetic and genuine, right? And we need to have the answers, okay? I also say marginalized populations, and I also say intentionally excluded populations when I'm talking about, quote, minority groups, okay? Because we are excluded. We are marginalized. Marginalized is pushed to the edge, pushed outside. Intentionally excluded means that we are not included in the data, in the research, in the treatment, that kind of thing. I forgot to put intersectionalities that I do include that. The research and data on suicidality and suicide treatment is very sparse with working with intersectionality, except for queer populations, LGBTQ populations. There is starting to be more data there, but there's not enough. There's not enough with intersectionality pieces of it. There's just not yet. And that's not my expertise, so I don't know why there's not enough there yet. I just know that it's not there. All right. Man, this slide was so cute. It had like leaves in it and stuff. So when I do talk about, because I am an advocate, this is why I talk about advocacy, and this is why I use the language that I use when I talk about marginalized and excluded populations, is because I'm using the ACA Code of Ethics. I'm pulling very specifically as an educator, my role is to do these things. My role is to infuse material related to diversity into all courses and workshops when I'm trying to develop and foster growth for counselors. And there's also a big old thing in the preamble, which why don't we never talk about that when we bring up ethics and stuff? Why do we always pull the codes? We don't pull that stuff here. This is what we do. We're honoring diversity and embracing a multicultural approach, and we're promoting social justice. And this is just, I put it in all my slides now because I got some feedback of like, why you always bring it up? Because, boo, this is why. Okay. I forgot we're being recorded. I am very casual, in case y'all can't tell. So, but this is why. So why are we here? Because as a clinician, the TAC says so. Y'all know what the TAC is? Yeah, these are the rules that say the stuff that you got to do. As a clinician, we are supposed to intervene and support in a crisis. You know, a situation in which an individual is an immediate danger to themselves or to others, or their health is at risk, their physical or their mental health, okay? And this is our job. This is our duty. This is part of the work that we do. Let me pause for a second here. Everybody here is an internship or practicum because this is Tex-CHIP, correct? Okay. Let me stop share. Who is school counseling setting? Nobody in Tex-CHIP is school counselor setting, right? It's all integrated. Who's inpatient? Inpatient? Outpatient? And that too. Y'all always have like a couple sites. Y'all trying to get them hours, aren't you? Oh, baby has both. Okay. Let me rephrase that. Who's in a hospital setting?
So I'm in an alternative school.
Okay.
Yeah, sorry, I thought you were asking like about tracks.
Yeah. Okay, alternative school, hospital setting. Y'all are in hospital setting also? Okay, who's in a different kind of setting?
Detention centers.
Detention center? Okay, CB Wellness? The CTC? Okay, where are y'all at? Juvenile? Hospital setting? Who did I miss? What other kind of setting are we in? Juvenile? Yeah, I'm trying to get a feel for who's in the room so I know what we're gonna talk about.
We got hospital, juvenile, alternative programs.
Hospital, alternative, juvenile. Do we have anybody in private practice in Driscoll Children's Hospital? Or Children's Hospital, is that Driscoll? Okay. Are you working with Stephanie? Dr. Majors? She's not work bestie. Well, she was.
Yeah, I definitely see her here and there. They're primarily on the weekends.
Oh, okay. Yeah. No, she doesn't work weekends very often. She left me. She was working here. Okay. That's right. I'm about to leave too. Okay. So y'all have already seen suicidal ideation then. Okay. So next time y'all do this training first. Okay. Good to know. So how supported do y'all feel in working with suicide? And this could be for the licensed clinicians as well, independently licensed clinicians. Like how supported do you feel in your working with students, or I mean with clients with suicidal ideations? Well, hold on. That was how comfortable you feel in working with it. How supported do you feel in working with suicidal ideations? I also know them, they're legit. You feel supported in inpatient? They got all that charting to do. That's why you feel supported in inpatient. Is that me? Who's texting me? In private practice, you feel scared. Oh, yeah. So yeah. So they were saying for people online, being in private practice setting, often working at night and being alone, starting that assessment and like, okay, what do I do and how's this going to go? And is it going to have to go a hospital route? Is it just going to go safety plan and just being alone? Heard. Okay. Challenging. Go ahead, Bethany.
I think I felt very
Hey, what up?
Okay, hi. I do think I felt very supportive. So I was at the Juvenile Justice Center, and even if my supervisor wasn't there, there was still always like another counselor, or she was available via text message, and just feeling like, okay, um, I'm not alone. And then there were other clinicians, whether it was a psychiatrist sometimes who was there, a nurse who was there. And then I also just got super used to it because we'd have to do screenings all the time. So that kind of helped. But as far as support, it was mainly just knowing that I had somebody I could reach out to who was going to come, and that there was also another counselor who was specifically going to do crisis assessments before I got to doing them. So I was trained, and I was also brought along to see the process.
All right, we're gonna segue a little bit, but it sounds like y'all know you need support, and I'm going to say, heck yes. Oy. So even though I've been doing this for a billion years, and I supervise other people, and as a director where I work, people have to come to me to sign off on their clinical documentation. People have to come to me when their clients are suicidal in order to consult. You know, we have to have it documented, that kind of thing. I still look for an adult to your adult. Like, I need an adult. I want to make sure that I covered my bases. I want to make sure that I did everything that I needed to do. And those feelings of like, are fine. And even though I'm a crisis specialist, I know that when I get to the point where where I'm just kind of like meh about it, that's when I got to stop doing that work. Right? I need to always be aware of like, how is this going to go? And to know that I always need support. Not to double check my work, but to, what did I miss? How can I make this better? Just to, did I miss anything? Okay. And especially as you enter into these different spaces right now, for the students, y'all have, you're supposed to have all the support that you need during this journey. And then as an associate, you're supposed to have all the support that you need. But when you become independently licensed, especially if you go private practice and you don't have a good support system with other clinicians, other professionals, it can be very isolating and very scary. Just putting that out there in the world. Okay. So the connections that you make now and the connections that you make at these kinds of trainings, conferences, and all of that stuff are going to be super important. Because this is part of the work that we do. This work is not going to go away, and we're going to get into that. I gotta screen share again. I'm parking lotting myself. See, Mira, look right here. It's real cute, right? Y'all see all the leaves and stuff? Man. It was cute. Okay. So let's briefly go over some myths and facts, okay? But y'all have already here, y'all already in the field. So yeah, y'all need to do this training first next time. What are some myths y'all heard of? What are some myths? Talking about it's going to make them want to commit suicide, complete suicide. Oh, like dying by suicide is the coward's way out. Okay. Anybody online? You can just unmute yourself.
Yeah, so specific to adolescents, they're just doing it or talking about it for attention.
Talking about it for attention.
Yeah, in the hospital setting, I've definitely heard parents say that if they didn't complete it, that they didn't want to die, and it was a cry for attention.
Uh-huh. I'm laughing not because it's funny, but because I've heard that. Anybody else heard any other myths? Who's ever had a suicide training besides the thing they make you do here for school? It's calling me. They can wait. Sorry about that. Okay, y'all had something. Those with suicidal plans and thoughts keep it a secret. No, they'll tell us. There'll be signs, typically. Caveat with all of this is that there's always the one, right? In general, there will be signs, there will be symptoms. If they talk about it openly, they won't do it. No, it's not just a cry for attention. Y'all are talking about adolescents and stuff. No, they might actually mean it. Once death is planned, it's inevitable. No, we can intervene. Talking about suicide usually decreases the risk of completion. People with suicide ideations typically feel relief. They feel better. This one is, I heard a lot of this outside of the mental health field. that you have to have depression or mental illness to have suicidal thoughts. And I have worked inpatient in the mental health field for a minute, and it's not always tied to depression or mental illness. You can have somebody with no mental health history, no depression, no nothing at all, and just life hits them with something and I want to die. Okay. And not everybody with suicidal thoughts and ideations needs to go to the hospital. People will fight me on this one, but not everybody needs to go to the hospital. We're going to go into some specifics about what that means, but these are just some myths that we've seen. This is a huge fact about suicide. So way back in my day, when I was very, very first a baby student counselor, one of my educators would talk about how, oh, in counseling, you're just gonna, really, unless you specialize, you're really just gonna work on everyday developmental concerns. And I went out in the world and went straight into MHID. And I was like, oh my God, she lied to me. But the fact is that no matter what branch or field of mental health work you do, it's not if you will run into a client or serve a client with suicidal ideations, it's a matter of when. So it's not if a client, not every client will have suicidal ideations, but over the course of your career, you will have clients who have suicidal ideations, plans, thoughts, means. When I used to work baby behavioral hospital, children as young as 4 and 5. It does not matter. So it's not a matter of if you will have clients, it's just a matter of when. So, anybody else scared yet? I think if I did this in the intro class, people would be scared, but you already been out there for a minute because y'all are in practicum and stuff. Anybody online scared? My license people online are like, ooh, who said
Negative.
maybe a little bit?
I said negative.
Negative. Okay, negative. Okay, cool, because this is reality, right? Oh, cool, as long as we're all together on that. You all know these already? There's three main categories of suicide risk: behavioral things, verbal things that they can either tell you or show you, and then situational things. Your job as a clinician is to use these three things together along with your clinical interview and your assessments to determine their level of risk overall. So when I teach these kinds of trainings for like the lay person, right, just the average person, I'm just going to teach them how to look for these things and make referrals, right? And this is usually just how far the books go when you're like in process class and you do your role play and stuff. You're just going kind of over these things. What you're going to be experiencing in your practicums and your internships and when you go out and like earn your associate hours and stuff is how to combine these things with this. Because we can notice all of this. Y'all have read all the books and y'all have done all the things, right? But this is what y'all need to practice with, is how to take this clinical assessment and make sense out of what's showing up here. Fair? This is the hard part. They're just saying or showing a thing, but what's the risk level involved? So this is what we're going to spend a lot of time going over today. Not a lot of time. I'm only here for 2 hours. But this is what we're going to go over. So just briefly, okay? And I have some asterisks here for the behavioral signs, the putting personal affairs in order and sudden interest or disinterest in religion. This is kind of starting to get skewed depending on generational differences. We're noticing some millennials and Gen Z not having personal affairs to put in order. So there's no house to figure out, right? But Gen X and boomers will have affairs to put in order. My fellow Gen Xers in the house are laughing with me. Okay. So there's just some differences that we're starting to notice along with behavioral signs for suicide. Okay. We're gonna talk about generations later. That's gonna be important. Who in here has heard me talk about generations already? Oh, you have. There's some other stuff in there too. From situational signs, the thing that I think a lot of new clinicians or new to suicide intervention clinicians miss is that there can be chronic and acute situations that can suddenly spark suicidal ideations. A person could have chronic situations like financial concerns for years and years and years that never really seemed to be a concern. But all of a sudden something, kind of like that, the saying, like the straw, it's like the last straw, right? And that might spark suicidal thoughts. Or there can be acute situations where everything else seems fine, but just the loss of a job or one of these other situations happen. And it's super acute. It's just right now. And it can spark the suicidal ideations. So kind of when we're thinking about the assessment piece is really looking at not just are things happening, but are they chronic, are they acute? Because this is going to help us assess for how severe the intent is, what the risk is, okay, and how we're going to help provide their treatment. Ooh, a lot more of y'all work with kids than what I thought would be. Kids are not my specialty. I love working with adolescents. Not a fan so much of working with families. Come fix my kid, that kind of thing. Not that that happens all the time, but I'm saying sometimes there's some additional barriers working with adolescents when families are not as involved as they can be. I hope I reframe that well. But sometimes adolescents will talk about stuff a little more vaguely. Can anybody clue me in on the new lingo? Because sometimes there's some underground lingo about how to say die and suicide. Murk? What's murk?
They never heard that? That's when they're like, I'm gonna murk myself.
I'm gonna murk myself.
Yeah, that's like an online term where they talk about like when they're playing games with each other, they say murk.
Like from online games, I'm gonna murk myself. Okay, see, that's why I bring it up, because I don't work with adolescents a lot, but I know there's lingo that's direct or indirect ways to talk about dying.
Or unalive, I think that's used a lot.
Well, unalive is because you can't, when you're posting like on TikToks and stuff, you can't put die, you have to like change the words. Censorship? Yeah. Hold on, can I come to you? Yeah, my boy, hold on. Sorry if you're all online, I'm running.
So what I found with adolescents though is like specifically like high school age, even middle school age, that they will just blatantly say whether it be like they consider it a joke or not, they'll just say like, oh, I'm gonna kill myself, like because they're stressed, or like something happened, like oh, like I deal with a lot of adolescents, who will just like God, like just want to shoot myself, like very casually, and that's where it blurs a lot, because there are like terms and stuff that they use, but then some also just openly joke about it, or like not even joke, like they could be very serious about it, but that's where it skews a lot, and I admit that's where I struggle, because it's like, okay, where are we going?
That's when thank you. So that's when the advocacy piece comes out of like, yo, we can't talk like that. Can y'all hear me online still?
Yes, you're.
Gracias. So that's when the advocacy piece comes out of. When I used to work inpatient, it was always adolescent unit. My job was the one-to-one as a mental health tech, always. Look, if you're not gonna tell me the truth, like we're not gonna use that language around here. If Anna's on the floor, if you tell me I wanna die if something doesn't happen, solitary, like I'm gonna call the nurse, I'm gonna call the doctor, like we're not having this language. When I worked at MHID with the youth, like are we doing an assessment or not? We're not using that language. And I would have to find out what the lingo is, unalive, murk, because then they start hiding it. What does that mean? Tell me. It does, it blurs the lines. Thank you for sharing that. But that's why when working with adolescents, or I work with a lot of college age kids, I have to ask, what do you want to die? When I think things are indirect, my language is very, very direct all the time. I need to know, do you want to kill yourself? Do you want to die? What do those words mean for you? Well, I just don't want to be here anymore. Like, you don't want to be in my office, or you want to die? I'm just going to die if so-and-so doesn't have, if I don't get Taylor Swift tickets, I'm going to kill myself. But are you really though? Because they might. 100%, somebody absolutely 100% might want to die, and to die by suicide if they don't get Taylor Swift tickets. I'm not discounting that at all. It could be life-ending. I'm not here to judge anybody's thoughts or emotions or perceptions of what they need to be alive, right? If I don't get into that graduate school, if I get a divorce, if I lose that job, if my leg has to be amputated, if I don't get Taylor Swift tickets, it's all the same to me. But are you really going to die? But yeah, when it's the indirect, it's a little fuzzy. What does that mean though? Does that mean you really want to die? Now it gets scary. Now does it get scary? Okay. Since you brought up the censoring for social media, this has become a little, I don't know, those of y'all who work with adolescents online also, I don't know if this has made it more difficult to look for the verbal cues, quote, verbal cues online because of censoring or not. I know it's still relatively easy to see with journaling, school assignments, you know, things of that nature. But with social media, I'm not sure if that's trending harder to see or not. That might be something to keep an eye on as you're working with adolescents. Hashtags are changing, that kind of stuff. I'm just putting that out there because it's so, and algorithms are messed up too. So what you see and what shows on algorithms and things. So just be mindful of that as you're working with adolescents and even younger children, as more and more younger children get access to social media and cell phones and their online presence, right? How do I say this? Their social media presence is their personality, is their presence more. There's not so much Finsta as there used to be, like fake Instagram. Their whole world is out there. People used to have like a fake Instagram account, you know? Now they're like, I don't care. This is all of me, right? So just keep an eye on this. I'm not sure what the trends are. I'm not an internet specialist. I'm super Gen X. I have no idea what's going on. I just have cats on my Instagram. I mean, my TikTok. Yeah. Private accounts are more common. There's a friends only option on Instagram? Mira, see? Okay, so. Oh. Okay, so they're sharing that there's ways online to like share to only certain circles. Okay.
Yeah, Twitter and Instagram, you can do that for sure.
Oh, now I gotta stop. They got rid of it on Twitter recently. It's not even Twitter though. I don't even know. 2 weeks. Okay. You're not calling it X. Okay, fine. Okay, so on the social media platforms, instead of people creating fake accounts, now they're just being more selective of who they're sharing with what, which might make determining some of the cues more difficult as the counselor, and for parents, for adolescents, to find these things, to bring to you in therapy, to share with you, unless, you know, siblings are ratting on their siblings or whatever. I don't know what that looks like in this age. Just to be aware of that. Does that make sense? Doesn't make sense to me because I don't work with adolescents. I just know it's a thing because I gotta stalk my kid's phone all the time. That's how I do it. All right, parking lot myself. What time is it? We've been here for an hour. Do we need a break yet? No? Okay. Okay. I thought we might need a break. Okay. Oh, no, I'm fine. I'll just make a stop if we need a break, if I need a break. All right, so we're gonna segue into discussing suicide assessments as clinicians in the field. What assessments do y'all use currently? Oh, let me stop screen sharing. Who's in the chat? Oh, off myself. I'm sorry, I missed that earlier. I can't see. Maybe I'll keep this like this. Stop share. Oh, yeah. What assessments do y'all use in the field right now, currently?
Safety.
Safety. And the Columbia one? In-house? Okay. What else do y'all use? Man, I'm not gonna teach y'all anything new then. So nobody else uses anything? Okay. An in-house one. There's a lot of in-house ones. Okay, so a lot of people are using in-house ones, and y'all are inpatient or hospital setting. Okay. How comfortable do y'all feel with using the assessments? Ah, I can do it. You guess comfortable. Okay. When I worked at MHID, I was a level of care 1 case manager for the adult unit, and my caseload at one point was up to 300 people, which is out of contract, by the way, just saying. But I would see, I don't know, I could see one person in 17 minutes just so I could bill for insurance. You know, do an ANSA and then a suicide assessment quarterly, get all that stuff done. So I would see, I don't know, 12, 18 people in a day. That's how many suicide assessments I was doing. That's a lot. So you can get into a habit where you get it done. And I don't want y'all to get there. Oh, I want you to feel, I would encourage you to feel comfortable asking all of the questions, but not like, they're okay. Because then. Mm-hmm.
But I was going to like Shoreline South.
Yeah.
So it would call these back by a certain time to call.
That's not how I do things. So doing things back to back often. Okay. So what I had planned for the training was to go through the I always put too many S's. CSSRS, that's why y'all got a copy of it. And that's just the screener form, right? Just to go through the components of it. And go through the components of a safety plan, go through some examples or through the components of the safety thing, the safety assessment. But it sounds like that's what y'all use. Y'all know how to do those. So I don't want to waste y'all's time. What would be more helpful for 2 hours of time? An hour and a half, whatever time we have left. The rest of the presentation that I have is like how to collaborate with families, how to collaborate with other providers, like some lessons that I've learned, some mistakes that I've made. What would be more helpful than going through an assessment if y'all already know how to go through an assessment? Or do you want me to go through it anyway? Like I'm flexible. You could use it?
I'm interested in here. I'm sorry if someone's talking. I can't really tell. I'm interested in hearing what the rest of the stuff you had planned, but I will admit that because I've worked at a residential treatment center, I've been a case manager at MHID, and then with the safety assessment now, I'm pretty well versed. But
Okay. Everybody else on, go ahead. Sure. They're asking a boundary question. Let me come to you. Is it a long question or can I rephrase it? Okay, then hold up. Okay. Y'all gonna make me get my steps in.
Okay, so just in terms of like, because I'm in the hospital setting, how can you like maintain appropriate boundaries and still help your client as much as possible if they're needing the help with suicidal ideations, but they're also using it as like a way of keeping you hostage, if that makes sense.
Keeping you hostage as a clinician?
Yes, like they actually they have suicidal ideation and there are attempts that go on that are legitimate attempts, but at the same time there's like an underlying cause for attention, like seeking help or love or something, and so they know that doing that will get them that love. Like how can you maintain like a healthy boundary without, I guess, feeding into it too much, but also providing them the help that they need?
Got you.
Mhm.
So there's a tricky line, right? To, I care about you as a human being. I care about you as a therapist. I like you as a person, and I love you as a person.
Yes.
Right? Isn't it hard? I like people. I love people. I don't love all people, but I like humans. Right? So if you've already felt like the boundaries are crossed, it's hard to say. It's a lot of backpedaling. And that's such a negative term, but it means like, okay, this is what I'm noticing. I'm noticing lots of outcries for love and attention. And I can't give that to you as a therapist. I can give tools on how to find that elsewhere. I am a therapist and not a friend. Period. There's going to be retaliation. There's going to be further suicide attempts. There's going to be further bids for attention. There's going to be further tugs at your heartstrings. So on your end, as a clinician for anybody, it's going to be getting with your supervisor, your site supervisor, your colleagues, and working through your personal feelings. It doesn't need to be counseling feelings, but your personal feelings of how can I be a good counselor and care about people, but not want them to die, right? Because we don't want them to die, but you also can't have them lean on you because you're not their family. And even as a family person, you can't be their only support, right? Which is what we do teach clients. Right? They need to have extended support. They need to have extended coping skills and these kinds of things. And then taking these opportunities now to learn how to set boundaries for future clients. Right, so it is a weird line of I want to be friendly, I want to build rapport, and I want you to trust me. And I'm a counselor, not a friend. Because we try to be our authentic selves. Like, I'm like this all the time. So people like me. So introducing myself as I'm a counselor, I really hope we get along, this is a good professional relationship. Just sprinkling those words in there and stuff so that they know that I'm real, but also that this is the type of relationship that this is. And so when I'm building out safety plans or I'm building out like responses to suicide attempts or other bids for behavior, it's reinforcing that. Like, I'm so glad that you really depend on me as your professional support, as your therapist, and how can we build out your personal support, right? Because you're only with me 1 hour a week, but there's 167 other hours of the week, right? So how do you build that personal support since I'm only your professional support? Language like that. helpful?
It's more of like, in the situation I'm having, or say, like, even though we've kind of established like, hey, this is a professional relationship, like, no matter what, it kind of gets thrown back on us, but, well, I mean, it's very, but, like, that's always been, like, oh, this inconvenience happened, I'm going to come. So it's like, how are we like maintaining, I guess like in our unit, it's also like a lived-in unit, so we're kind of like, how are we maintaining a respectful boundary, like, and teaching that like professional
Mm-hmm.
relationship simultaneously and not wanting them to engage.
Yeah, and I'm going to pause you right there because this is also a systemic piece. You're a student, right? Where are your site supervisors? Where are the fully licensed individuals who can divert some of this? Who can build on their clinical experience? Who can bring in the full breadth and knowledge of all their tool bag and to further set boundaries. I mean, you're there at most 20 hours a week. If you're an internship, that's the max you're supposed to have or whatever. Am I right? Close enough? Close enough, doesn't matter. You should not be, and I mean you as in students collectively, should not be in the carrying the burden if it's that intense as what it sounds like it to be. Where's your site supervisors? You don't have to answer that, I'm just saying. You know what I mean? That's something that needs to be.
I feel like this is not my, this is something I.
Yeah, so something to advocate for. As a site supervisor, I'd be stepping in, like, hold up, get out of the way. No, these are my students. Hold up. You need to be doing your work, or as a client, telling the client like, okay, this is what I'm noticing. These are the patterns. Let's do some DBT. Let's get you into these other treatments because your coping skills, you have none. How is a minor life inconvenience? And now you want to die, right? And again, I don't have the whole picture. I don't have the whole story. So you were going to say something. Do I need to come to you?
No, it's okay.
Okay, go ahead.
It is a system, and it has various and various and not itself. So there's text, there's nurses, there's therapists,
Yeah.
all of that. And I wonder then, like, in an effort to elicit those boundaries and to not reinforce those behaviors and to lash out if you feel wrong, using self-harm,
Mhm.
suicide. How could we approach it from the grade?
So how can you reinforce those boundaries from an integrative setting standpoint to reinforce the boundaries overall? Okay. Remember, a lot of people don't sugarcoat things. You can advocate as a student, you can advocate from a perspective of curiosity and questioning. You probably have very little to no actual power at the setting. I'm saying systemically overall as students, they're like, meh, look at the student. Like they're saying that we need boundaries here systemically. What are they gonna, they don't know nothing. They just need their hours. However, advocating, and I say that with all my privilege of having a whole PhD and, all of that stuff, like, because I can come in places and say things, right? And as a student, you don't have that privilege, that power. That's political power, right? But curiosity of like, hey, I'm noticing these things. And so I'm feeling really uncomfortable. And so how could we set these boundaries? How could we do these things, right? How could we make this work better? What would that look like for you as a student? This is what it would look like for me. And then as you progress further, being firmer with those boundaries and firmer with those statements. I know I don't like that answer either. Remember, a lot of people don't sugarcoat things. I think Dr. I missed that part. I had a whole slide that said it. Yeah. All right. Online people. So you still want to, and then I got some feedback in here that you still want to hear me go through what I was going to present anyway. But if you wanted to add some stuff, then we can add some stuff. We can parking lot some stuff as we get there. But yeah, I think next time we'll do the suicide intervention training first in this series instead of like last when they've already had some experience. Okay. I'm parking lot myself because all the stuff. Right, I forgot where I left off. You know what, before we do this, people are starting to take breaks, so this seems like a natural place to take a 10. Fair? All right, do I pause recording? Okay, come back in 10. Where is that here? Yeah, I was just going. Yeah, because I don't, it's because I don't like being recorded. Okay, so we've decided collectively, y'all and the people online, that y'all want to see what I got anyway. So I think what I might do, I don't know, I'm gonna figure it out when we get there. But we're still gonna go through it all together. We're gonna go through, what I brought today was to walk through an example of this CSSRS. But I only brought the short form version with me, the screener, because I want to make sure that we really, really understand the key questions that we're asking. So I'm gonna go ahead and share my screen again. And I figured out why my pictures weren't working. I think we did. But I'm going to, maybe it's gonna work. Okay. So CSSRS is super duper duper common. And kind of really all suicide assessments cover most of the same things, right? They're asking about lethality, they're asking about means, they're asking about intent. They're really getting at what is the risk level, okay? I personally really do like the functionality of the CSSRS because it's easy for a lay person to use. And that's what I like to use when I'm teaching because it's super duper straightforward, right? Especially for entry level, if you can teach it to first responders who are just like out in the field doing stuff, or just teachers. I don't mean just like they don't do enough stuff, but I mean like they got to pick it up on the fly. I like it, right? And it's very widely studied, right? It's got a good evidence base behind it. And there's lots of different versions of it. I think last year, Dr. I might correct me, last year, maybe the year before, they changed the language for like 6 to 10-year-olds or 6 to 11-year-olds. They added a version. So I like that too, right? Because remember, even little ones can have suicidal ideations and thoughts and plans. So I like that. And it's free. It's full free. Like the BSI, the Beck Suicide Inventory, is not for free. I forgot to bring a copy from my office. And I was like, I'm not gonna go buy a bunch for y'all. But I'm not that giving. So I brought just the screener today, and that's the copy that y'all have. And everybody online should have gotten a copy of it. If not, you can Google it for the screener version. And when I turn this PowerPoint in, the links are all on there. So it's basically the first 2 questions that you're always gonna ask are, do you wanna die? And have you had any thoughts of killing yourself? These are some sample questions on the form that y'all got. I'm showing people online. It's just a PDF. That's an example of how you can say it, okay? I am much, much more direct when I ask this question. And I don't ask more than 1 question at a time. So this example here is, have you wished you were dead or wished you could go to sleep and not wake up? I don't stack questions when I'm doing suicide assessments. I just ask one. Stacking questions can lead to confusion. It can lead to somebody potentially, if they're scared or hesitant, we'll go into why later. But it can lead to them evading if they had a need to. So I just ask, have you wished you were dead? Do you want, or I ask, do you want to die? Have you had thoughts of killing yourself? So my recommendation is don't stack the questions. Then I asked, have you had any thoughts of killing yourself? If they answer yes to one of those, then I'm going to ask all the questions. But if they say no, then I'm going to go to number 6. So they tell me, I'm going to ask them, have you had thoughts of killing yourself? Do you want to die? No. Okay. Have you ever done anything in the past to try to kill yourself? No. Go ahead. What amount of nonverbals do I contribute to believing their no? A lot of it. I rephrase it, or I ask the second part of that question. So the question was, maybe they're a little hesitant about it, or maybe they don't look at you. Taking into account cultural factors or something, right? Well, no, I haven't really. Okay, well, I'll call them out on it too. Well, that wasn't a really strong no. Let me ask you some more questions. And so then might ask these follow-up questions as well. So I'm glad you asked that question, because even if someone tells me no here or here, number 1 or number 2, and I don't feel real good about that no, it doesn't mean you always go straight to number 6, okay? You can ask all of these no matter what. And actually, when I'm training students on site, we have them ask all of the questions no matter what. Every single client when they come in. Ooh. Because sometimes the flavor is the word that I use. Maybe the flavor is off. Not really, or maybe not, or something's a little indirect maybe. So have you ever thought about how you might die? Have you had these thoughts? I don't like the way this is worded. Have you had these thoughts and had some intention of acting on them? That's kind of a chunky question. But what they're trying to do here is ask about intent. So I ask, do you have any plans to die? That's what I want to know. Do you have any plans to act on that? And then the next one is, what is your plan to kill yourself? The other thing that I ask here, that the trainer that I talked about in the very beginning, what he told us and why I always ask it now is I ask about, what's your backup plan? Oh, my plan is to, yes, I have plans to kill myself. I want to jump off the harbor bridge. Okay, I know you don't have a car. What's your backup plan? Oh, well, I can get pills. I can get a gun, or I have pills, or I have a gun, whatever the case may be. So I always, which is not on here, I always ask about, what is your backup plan? And depending on how they're answering me and the feel that I'm getting, any other plans? Any other current plans? And then, do you intend on doing that? Even if it's outlandish, and I'm going to sidebar, even if it sounds outlandish and wild, I'm still going to document it and I'm still going to ask it. I had a client one time who was immobile. He had to use a wheelchair. And so his plan was to jump off the harbor bridge. No car, very weak upper arms, so needed to have a homemade to push him in his wheelchair everywhere. There was physically no way he was going to push himself in his wheelchair up the harbor bridge to then throw his body over it. Physically, I mean, my brain is like, dude, there's no way, right? I'm still like, okay, I hear you. You absolutely do want to die. That is a very concrete plan, is that you want to jump off of the harbor bridge. Clear? So there are some examples here for number 6. Have you ever done anything, started to do anything, or prepared to do anything to end your life? Again, this is a chunky question. They're asking about like, what are you doing to prepare? What are your means? And then, how recent was this? I don't give it a time frame. I want to know how recent. When was the last time? Were you planning last week? Okay. When was the last time? Oh, it was a while ago. What's a while ago? Especially working with young adults. Oh, it was a long time ago when I was in high school. Mijita, you're 19. High school was last year. That's not a long time ago. But in their mind, it is a long time ago, right? Or when I was working inpatient, oh my God, that was such a long time ago. That was like October. Bruh, it's December 2nd. You can't tell me that was a long time. I mean, it is a long time ago for them. So very, very clear. I personally do not use the 3-month guideline that's on here, depending on the age group that I'm working with. But it does give you some indicator of how intense the risk is, depending on the level of means and such. Right. Those of y'all who work with kids or have worked with kids in the past are giving me caras. Y'all giving me faces like, that's right. How does that feel? Thinking about longevity, recentness, what's a long time ago? That was 2 weeks ago. That was a long time. Oh yeah, 2 weeks ago was forever ago for a 12-year-old. Okay. Yes, relevance to them, especially little ones. Yes, 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 yes. Go ahead. Yeah. So little ones say it was yesterday, or they don't remember details, or they were like, oh, I don't know. But then they'll remember details later. Oh, I don't know. I don't know what my plan is. I thought I had a plan, but I don't remember what it was. Okay. What I used to use in the hospital a lot, and when I worked at Robstown with youth a lot, was I used to give one I don't know per session. I literally had index cards, and I wrote I don't know, and I would give it to them at the beginning of the session and say, that's your one I don't know card that you get per session. And once you use it, you can't give me any more I don't knows. And sometimes they would hold on to it like this. Like, I gotta save it. And once they used it, oh, you already gave me your card. So that means you have to answer the question. You ran out of I don't knows. What I like to use with little ones, that works with adolescents. Little ones are like, I don't know. Well, you don't know, well, they're super little. I'm thinking like elementary school. Having a hard time answering some of these questions is changing your language, right, to match their language. And if I'd known there were so many people working with children, I would have brought the adolescent version in, so I apologize. The 6 to 11 version, pediatric version, I'm sorry. I changed the language, right? But I also say, if they say, I don't know, I say, well, if you had to guess, what would it be? Or if you were to tell your best friend, what do you think you would tell them? Right, that way they're not pressured to tell the big scary lady in the counselor sweater.
I used to, so when I did like, I was like, when I worked at CIS,
Mhm.
and I worked at primary school.
Pre-K.
And there was like, okay, that would be better. Your best friend.
Yes. You should tell it to your best friend.
I don't plan to work with kids, but I did before. That was the plan.
You just happen to work with kids, but changing the language to like, you don't have to tell me, but if you were to tell your best friend.
There was one who didn't, who said that they didn't have a best friend, but they really liked more character. I think if you could character, because they like to like interact with like the
Oh, yeah.
like you could explain it to this character.
Mhm.
How would you tell it to them? And so that's
So for the people online, explaining, like working with super little ones, working in like pre-K setting of like, oh, if you could explain it to your favorite doll or explain it to this character that you enjoy, how would you explain it to them? Because some of this language is weird. And with what I call big emotions and working with little ones, is that they don't know, they just know that they don't feel good. They just know they don't want to be here. They may have the language for dying or for suicide, but they may not. I mean, my kid does. That's because he's come to me with these trainings, you know? Average kid doesn't know. They just know they don't want to be here, right? We do know, however, that younger and younger children, younger and younger adolescents do have the language for death, suicide, means, intent, and plans. TikTok therapy. So being very direct and asking these questions is working, usually, regardless of the setting, okay? So going back again, just to review, because that was a little bit disjointed, okay? So asking and introducing the assessment, which I think is a clunky part that a lot of newer clinicians don't have. And what I use is the language of, I'm gonna switch gears. So I'm gonna switch gears here and ask about safety and risk. These may or may not apply to you, but we ask them of everybody. And my number one priority is always to make sure that you're safe, right? And we'll go from there. So switching gears, I'm gonna ask about safety, okay? Do you have any thoughts of killing yourself? Yes or no? Okay. Do you have any intent to kill yourself? Any thoughts of killing yourself? Okay. Do you have any, how have you been thinking about doing that? Do you have a plan to do that? How likely are you to do that? What's your method of how to do that? Are you preparing to do that? And by that, I mean like hang myself, shoot myself, whatever that may be. Personally, I also always say, thank you for answering those questions. I know that can be really hard. I know that can be really challenging. We've just met 30 minutes ago, and that can be really rough. So I appreciate your honesty there. Even if I think they're being sketch. Thank you for sharing that with me. I know we just met. And now I'm going to switch gears again and ask about whatever it's going to be, right? It kind of depends if I'm doing an intake or if I'm doing a brand new consultation. Because we can, and this is not on a slide I put anywhere because this is kind of, I didn't know what we were going to talk about. You do a suicide screening whenever. It's not just a one and done. I'll stop in the middle of a session like, hold on. I'm feeling a little, let me check in with safety. Let's switch gears. That story you just told me, something's not sitting right. We've been working together for a minute and this is not, hold on, let's switch gears. Are you thinking about killing yourself? Do you have a plan? How do you want to feel that? How do you want to feel that plan? What's your intent right now? Okay. Etc. How does that feel when I walk through it like that? takes practice. And sometimes I'll hard stop, like, it depends on my relationship with the client too, my rapport. I'm in teaching mode right now. But, you know, I'll be with a client and be like, whoa, hard stop, hard stop, hard stop. Did you try to kill yourself this weekend? Let's switch gears. Switch gears. Do you want to die? Let's talk about it. Remember, we always gotta be safe. What's going on? I mean, I do it all the time. It does, but also having those conversations with your clients from the get-go. I'm always gonna be checking in on safety. And it's gonna depend on your site. I'm gonna stop sharing for a second. It's gonna depend, and I'm sorry for my independently licensed clinicians who are here, and this is a review for you. It's gonna depend on your site too, right? Where you have some different protocol of every session you're doing a risk assessment, or you're doing it with an intake, or it's built into your biopsychosocial assessment, or it's a self-check-in screener. Like in private practice, there are some, I think Simple Practice and Therapy Notes will let you send out like a PHQ-9 or something, like before you check in or whatever, like it kind of, it's built into systems differently, right? Some places only do it as needed. So it kind of depends. I didn't put that slide in here today, but usually I have a slide that says, it depends, because everything's so fluid. But just getting into a flow and putting it from the get-go, from the jump, like, hey, if I ever feel like your safety is at risk, from those limits of confidentiality, right? My name is Dr. Salazar. My pronouns are she and her. You can call me Ana. Before we get started, let me talk about my legal stuff. You know, everything here stays between us. There are some limits to that, though. If I think you're going to hurt yourself, hurt somebody else, if you hear about child abuse, elderly abuse, disabled person, before I get subpoenaed, do you have any questions about that? And if they usually say no, let me be a little specific, though. We're going to work collaboratively together. This is your journey. You're the expert. When I talk about safety, I'm always going to make sure that you're safe no matter what. Always, always, always. So I'm going to ask that every single time. And if we got to dig into that, then we're going to dig into that. Right? So just kind of laying it out there from the get-go. Not just checking the box of like, I got to say these 5 things when I do my confidentiality thing. I mean, my limits of confidentiality, right? So building it into the relationship, building it into the rapport of that you are safety-minded. Mira, your spaces. Let's do a restorative breath together. Oh, Bethany, you needed that one, didn't you? That also helps with the boundary setting, like y'all two were talking about, because this is a professional relationship and this is how we're working together. You know, I mean, I celebrate with clients in office too. I'm like, yes, I love that. No. And I'm like, no, leave him. No, you know, we get all kinds of personal in there. But I'll also, hard stop. Hard stop. Hard stop. You are, you're not dying today. We're gonna talk about this. Make sense? Okay. How y'all feeling online? Hi. All right, let me, okay. All right. Excellent. I have lots of thumbs up, thumbs. I like the little emojis. I like when people use them. All right, let me go back to my screen because I don't even remember how much I have left. Not screen share, PowerPoint slide share. All right. So that's just the CSSRS. The other one that is really, really commonly used is the safety assessment. That's the other, oh no, I'll put it online. but it's also free online. They used to give out fancy schmancy, that's a safety plan. Not yet. They used to give out fancy schmancy little cards from SAMHSA, but they don't do that anymore. But now you can download a PDF of this. It looks like, did I print one? I didn't print one. But it's basically this blown up front and back, right? This has more examples of what you're asking for as far as the risk, protective factors, suicide, how you're asking about the suicide. I can't even read that. That is so tiny. Oh, it's so small. You're gonna ask, that's 5 steps, right? You're gonna talk about, what are the risk factors? Remember, because we're going to be assessing them. We've identified, I know it's tiny. I see you staring. Looking at protective factors, right? So they say they want to die, right? But we're looking at the risk factors. We're looking at the protective factors. We're looking at like all the interventions we need to do. And then the piece that's on here that I really like is a reminder to document, which we're going to talk about. We don't talk about documentation enough in our counselor education programs. Document, document, document. Document, 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 document. Yeah, if you don't document, it didn't happen. And document like you're always going to court. Okay, I know that's scary. All right. So their recommendations for the safety assessment is that suicide assessments should be done at first contact with any suicidal behaviors, if they have increased ideation, any clinical changes that might be like you're seeing suicidal behaviors, situational clues or whatever, that kind of stuff, okay? There is a version, and I didn't print it out, but there is a version of the CSSRS. I did print it out. That's what I brought. There's a version of the CSSRS with the safety, with this integrated into it. So if they already have suicidal thoughts, you can, I didn't print it out, but I'll email it to Bethany. So there's a version of the CSSRS with the safety assessment built into it. It's really neat. Yes. Yeah. Passive thoughts all the time?
No plan or intent, but
Yeah,
it's just
that's a thing.
chronic.
Yeah, that's a thing.
Okay, that's what I said, but I wasn't sure.
Yeah, it can be a thing.
Could be. There's no plan or intent, I mean,
Correct. Typically, you can't admit into the hospital. I mean, it's always the hospital's inpatient criteria or intake assessment that determines hospitalization or not. But having chronic passive ideations is a thing.
just that, oh, I wish, it'd just be better if I just.
Yeah, I mean, I might make some recommendations as a site supervisor for how to determine treatment. I might be doing, we're gonna talk about that. Parking lot. So I recommend going through this because this is kind of lengthy, because this gives you some good things to look out for. So when you're digging into the ideation, you're looking at the frequency, the plan, what is the timing of the plan, what is the location of the plan? So just my example of the gentleman with the wheelchair in the Harbor Bridge, I wanted to know all of those pieces for that plan. Outlandish as it seems, I wanted to know all of those pieces of it. Oops, move that out of the way. Why is it, I don't know why it says no title right in the middle. And what I'm also looking for is intent. Active. My gentleman wanted to go today to go to the top of the Harbor Bridge to kill himself. Yeah, I don't care if it was actually actionable or not. The intent was that he wanted to do it today. The intent was there, okay? Versus like, eventually when I get strong enough, maybe I'll wheel myself to the top of the Harbor Bridge. Okay, that's a little more passive. It's still a solid plan, so it's still a lot of risk, right? But the intent was not very clear, okay? Depending on the level of risk, which is why I like this version of it, because the CSSRS just tells you if the risk is there or not. This tells you what to do with the risk. So the version that's integrated with both of them together is lovely. So this one tells you what to do with the risk. There's high risk, moderate risk, low risk, and then how to document. What am I doing today? Tomorrow I can email Bethany so she can email out next week this version of the SS with this thingy inside of it. Okay. So I'm not necessarily asking the questions on the safety when I'm working with the client, but I'm assessing for the stuff that's on here. Okay. So that's why going through this really thoroughly to know what pieces you're looking for when you're asking those questions. Oh my gosh, you gotta study. You gotta look at stuff. I want to talk about treatment and interventions. This is where it gets a little muddy, especially as newer clinicians or clinicians who have been in the field for a minute and get hit with something that's new, or maybe start working with different populations or switch jobs or careers or something like that. So typically what we see in a lot of literature is even the CSSRS, right? It has yellow and red spots, right? And the risk goes up, and so the intensity of the treatment goes up, right? Kind of the basic level, there's a little bit of risk is that we have a safety plan, and then maybe you need some increased treatment, maybe intensive outpatient, maybe you need partial hospitalization, maybe you need inpatient services, right? So 1 through 5, it goes up, okay? What I would encourage clinicians to do, and what I try to encourage clinicians to do, is instead think of risk level as always changing. Risk level is a continuum this way. The story that Dr. Maravata shared this morning of the young woman who was inpatient, who was actively suicidal and then went in and was like, nope, not anymore, right? Or the young woman from the case study we had this morning also, right? She had a precipitating event. There was something acute that happened and just, you know, triggered her emotions, right? Or somebody who's having chronic, maybe the chronic passive ideations, or having chronic physical pain, right? They may be on a spectrum like this. When we get stuck in a clinical rut of thinking of risk only on an up spectrum, we might miss things. We might miss interventions. And so I just encourage thinking of these needs as always on a spectrum, and not necessarily always thinking about interventions as being assigned a number to a risk level, because any number of these interventions can work and could be used at any one of these risk levels. That might be an unpopular opinion, but that's what I use in my clinical work. And let me move this out of the way. How do I move that? I don't care what level I'm doing. I don't care if you're going inpatient, PHP, no matter what. You leave my office, you're having a safety plan. If you have suicidal ideations, I don't care. Hard stop. That's just how I roll. Even if you are going straight into the intake department to go get assessed, you are leaving my office space with a safety plan, period. That's how I do. So say Jimmy is taking Sharon to go have an assessment at the hospital, right? Roommates, besties, I don't care what scenario you imagine. But Jimmy is taking Sharon to the hospital for an intake assessment. Sharon convinces him on the way, like, no, I'm fine. Let's go eat first. I hear that all the time. Can I get some food first? Nope, you're going straight over there. Whatever. And they decide not to go. But there's no safety plan. I didn't make a plan with her. Her plan was just to go to the hospital. Or something happens, or I don't know, or they don't admit her. Maybe their assessment was that she didn't need to be admitted. So I always, you're leaving my office with a safety plan. I know I just said that 8 times in a row because I want to stress the importance of it. Safety plan. And make sure they write the safety plan. I gave you a copy of safety plan. This is I don't even have a copy of my own safety plan. Let me go get one. That's what I get for sitting down too long. Okay. No, it's my bad. I should have printed one. I gave it to you. So this is a very, very basic safety plan. They almost all look like this, and this one is for free. All right. They all cover the same things. What are your protective factors? Wait, how do they call it? What are the warning signs of when your risk might increase? Who are your support people? What are your internal coping strategies? People that can provide distraction. Who can you ask for help? Who are agencies you can call during a crisis? And then how can you do means safety, like reduce access to means? Never, ever, period, ever, do a safety contract. I don't even think they use them anymore. They don't, but some old school people still use safety contracts. Don't. Period. There are some people, older clinicians who will use like Jimmy's gonna sign this contract, and I promise not to kill myself. He's gonna sign it, and then I'm gonna sign it as a clinician, and I promise not to kill myself. Don't do that. 1, it's a legal liability, and 2, you don't want that on your conscience, and 3, they don't work. So don't do that. They're really outdated, but we still have lots of old clinicians in the field who are trained in old ways. So don't do that. That's my recommendation, and it's my training, so don't do that. Go ahead. Oh? Do they really?
Did not say it right from the beginning, and I'm so glad that you had said that, because I was like, I don't like that.
Ooh, we can chat offline because I know who the director is. I went to school with her. Tell.
So with, like, my particular client, like a safety plan with them.
Yeah. Yeah. Hey, Dr. I.
I didn't say anything, so I was like, oh, that's just how they do it, but in my head, I was like, black part.
Yeah. Well, it's also not your license right now.
Yeah.
And when you're an associate, that's somebody else's license. So like if you were under my license, I'd be like, you ain't doing that. You ain't signing no contract under my license.
Yeah, like, I haven't done any of my clients.
Yeah.
But I've seen them do it, like, so I thought I was like overreacting or something.
I don't know. Okay. They don't work. They don't, evidence shows that they don't work. So when I put on here, be creative, not prescriptive, I mean, know what this is, have it memorized. If you have a client that has maybe been in therapy for a long time, oh my gosh, especially an adolescent or a young adult who has done one too many of these, which could be just one, because, 14-year-olds, if you have somebody who has done one too many of these, or is hesitant, or they don't work for me, have the steps memorized and call it something else. Right? Let's create a plan to keep you safe. What's going to help you be distracted? What's going to be a distracting plan? What's going to be a coping plan? What's going to be a growing plan? What's going to be I've called it all kinds of stuff. And what I'm doing is creating a plan, writing it down on a piece of paper, or I'm doing notes on their phone with them, taking pictures of stuff. Who am I going to call? Pinning it to the top of their contacts list, adding it to favorites. I'm being all kinds of creative to keep them safe. I'm documenting it. We identified 3 contact persons by saving them to their favorites in their phone. We identified 3 methods to increase coping by highlighting whatever this playlist Spotify thingy is. I don't know, whatever. Because they're making it, so I don't remember what those steps are, right? I'm being creative, I'm doing things, I'm following this methodology where I'm looking at restricting means, finding support people, that kind of stuff, but I'm doing it in their language, with their words and their methods. Because I don't know how many times I have done these versions and they've come back the next session, oh yeah, I have that. Let me pull it up, let me pull it out of my back, let me pull it out of my back. Oh yeah, I have it. You mean this thing? You mean that thing? Oh yeah, I forgot to use that. Or like, I don't know where I had that. Or I find it in the bathroom or something. So not all clients. There are some who are like, this is mine, right? And there are some who are like, okay, yeah, I got my safety plan. Am I lying, Dr. I? Am I good? Is that true though? I'm just checking. I'm on point, okay. The floor of their car, that doesn't mean no damn good, no darn good when I'm out the house. Oh, yeah. Like you forgot your plan, dude. So this is what I mean by be creative, but know what you're looking for. You're trying to identify those coping skills, reduce those lethal means, etc. What the French? Oh, wait, we don't need a break because we just came back from a break and we're gonna run out of time. Is it already 12:30? Wowza. Let's talk about restrictive means. In my experience, the best clinical treatment when you're working from this perspective is always least restrictive means. This means that even if someone has intent, there have been occasions where I have not recommended hospitalization. That has not been the best course of action. Again, it depends, and you're not going to go everything before you leave. And there was lots of consultations. There was lots of stuff that I went through with lots of different people of like, what else can we do? There was lots, there wasn't just safety plan with one person. There was all families involved, all kinds of stuff. And besides that, they have to be voluntary to want to go to the hospital, to want to get that higher level of treatment. Personally, as a clinician, ethically, morally, because it is very, very rare for me to pull a warrant, for me to put somebody on emergency detention warrant. And I've been doing this for a long time, and I worked at MHID for a long time. I worked inpatient for a long time. I mean, when I told you at the very beginning that crisis work does not drain me, when I have to pull a warrant, those are the days that get me.
It's hard too, cause like out of the ocean, and even with me saying exactly what the patient said, nurses saying exactly what the patient said, the patient spoke to the police and was like, no, blah, 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 and they're like, well, we can't.
Oh, well, I don't know.
They're already like in intake.
Well,
No, that's not what happened.
it can be challenging systemically to get a warrant. It is hard unless you go straight to the judge, which you can do. Some judges are more receptive than others to writing a warrant for you. And it depends on the collaborative relationship that you have with your local police departments, that kind of thing. And I just hate to do it. I will sit with you for 2 hours. Actually, that's my personal time limit. Like, we tried for 2 hours to keep you alive. There's some leeway there, but you know, like we gotta think of some options, buddy. Let's go. Be mindful when you are referring for higher levels of care, and if you do have to get police involved. You might see this in community care, just even for transportation issues, needing to call police, needing to call maybe an ambulance, maybe needing to call a probation officer, any of those things. Just be mindful, not mindful, I need to change that word. Don't be mindful, be knowledgeable that when you call 911, not all responders have mental health support training. And this can be dangerous to many, many groups of people. People may die if you call the police for mental health care. Is that clear? Okay. Don't be afraid to call somebody else. Like, I do want to get you some help, so can we tag in somebody? Can you call your auntie? Can you call your neighbor? Can we call your pastor? Can we call somebody else? Do you want somebody else here with you? Right? Okay. Restorative breath again. This is the world we live in. This is the reality that we are faced with when we are doing crisis mental care. And this is also the number one reason, not the number one, but there's many reasons why. This is one of the top reasons why I hate to pull warrants. Because there's many, many ramifications. We're running out of time. But let's do another deep breath together. Thank you. I always need a restorative breath. Okay. I know we're running out of time because we started late, but I have to leave it on at 1. Okay. My bad. So how do we consult about suicide risk? Y'all don't have to do much of this yet. Most of y'all. I mean, there are some people who are online who are licensed, I think. But y'all will be consulting with your supervisors, and then when you're associates, you will be consulting with your supervisors when you have someone with suicide risk. But you should always be consulting. I didn't want to cough in y'all's ears. This is the piece that I think we miss when we're training, is that we don't consult directly with the client about it. We start consulting with the support people, we start consulting with the other professionals, but remembering that we're consulting with all three when someone's having suicide risk or intent, planning, everything. And these are the top 4 things that I always say. Be very specific, be kind, be patient, and be firm. I don't know if Dr. Madhavala or maybe Dr. I, both of y'all said it, like y'all are the professionals. Y'all will have full master's degrees, full licenses. Y'all don't give me nothing about provisional license, whole licenses for whole professionals doing this work, okay? You have done assessment, you've seen the risk. Be firm and be specific. Always get verbal consent at the very, very least when you start this process, and then throughout the process, get written consent for support people. And you're gonna be telling them stuff like defining the goal. Always define the goal and the reason why you're reaching out to talk to them. I'm concerned because Anna has told me that she has thoughts of killing herself, and I believe her. I have noticed her symptoms have been increasing. We discussed ways to keep her safe. I am recommending the best course of action is that she get help going for inpatient assessment. Very direct, very specific. There was no ambiguity in there. I could have said it a little softer, but you know, I'm concerned. I'm concerned. Anna has increasing suicidal thoughts. And this is to talk to a parent, and this is, I think, to answer, I don't remember who, I forgot who had the question about how to talk to a kid or a parent. Oh, it was you. This is what you say. This is what I'm noticing, and this is what I see. And this is my clinical recommendation. Period. The more we add to this, just like stacking the questions from the risk assessment, the more we add to this, the more confusing it becomes for the support person And you can also use this for the client. Anna, I'm really concerned because you just told me that you had a plan to die. This is new for you. And I think we need to do a safety plan. I'm seeing increased signs, etc. Other providers, since this is integrated, right? What if I need to call the doctor, a medical doctor, or a psychiatrist? Or if I need to call their probation officer, or I need to call their school teacher, right? We still need to contact these people. Be very, very clear. No chisme, no tea, no gossip, right? And it's easy to do because I will tell you why in a second. But always make sure you have written permission. When you're working with adolescents, especially when they have risk or children, you should ask parents, it's best practices, and what I encourage my associates to do, because I don't work with children, but they do, is to get all the consents up front. Just get written consents for their whole team. If they have, just get consents. That way they're already on file. And tell them why. Like if you're coming into therapy and you're having problems at school, it might be best practices for us to go ahead and have these consents up front. That way when there is an emergency, you're not trying to remember, oh my God, did they tell me that they have an IEP, what's it? IEP plan, IED? I'm forgetting what it's called.
For school?
Yes,
Yeah, individualized education plan.
yes, yes, I forgot what it was called. Like, instead of trying to remember that when it's in crisis, when you're doing their intake and they telling you this information and they already have that stuff, be a little preemptive if they know, if you already know they have those needs. Again, defining the goal and the objective of the consultation. I have referred Anna for treatment due to reports of suicidal ideation and increased substance use. Just informing you. I'm informing you of my decision to refer her for treatment. I'll update you when I have more information. But if there's pieces of the puzzle, like say there's a psychiatrist and you, making sure you're clear with who's doing what. This often gets a little muddy. I'm understanding that I'm going to follow up with them when they're discharged, and then you're going to call them to get their psychiatrist appointment. That's just an example, I don't know. Who's gonna do what? That way you're not mistaken for the case manager, or maybe you are the case manager at that point. Maybe you are helping them manage that case. Just being clear of who's doing what. I am understanding, okay, I've informed you that I sent them to the hospital. I'm going to do A, B, and C, and you're going to do X, Y, and Z. And then documenting it. These are some things we run into. We over-explain. We call them and then we, all the stuff that we said, all the stuff that happened in session. If they wanted to know, we can send them our notes if we have released information. Right, we're just informing them it's a phone call or a quick fax or whichever methodology. Because some people have different styles of communication. Some psychiatrists' office don't want the notes. They want a face sheet with the dates of admission, and that's it. Some medical providers do want the last 3 months of your notes, or it depends. We don't know. So there may be some differing styles of communication. Some schools want way too much information, and you have to set some boundaries. Because some people are a little territorial. So some of the pitfalls of working with other offices, oh, well, I'm the school counselor, and so I need to, no, you're the principal. You don't need to know all that stuff. Like, I just need to tell you that they were out and that they're gonna come see me. Or you're the cardiologist. I'm just, like, it was a courtesy fax that their medications were changed. Like, you don't need to know all the stuff. But some offices can be a little territorial. That's my patient. Just saying. Doesn't happen all the time, but it can happen. Medicine, they may need different information. Consult with supervisor peers. I've run into weird things where cardiologists do need to know all kinds of weird stuff about all kinds of things that happened inpatient, and I just don't know and have to consult people. These are just things that I've run into working when I've had to refer people for inpatient. There's also sometimes systemic power differentials. Like when I said earlier about like you being mistaken for a case manager or a social worker. Like we're not trained as case managers or social workers. You're trained as clinicians. Beware if you have been case managers of falling back into case manager role. There is a component of case manager-esque work inside counselor. And your job is emotional support. Getting them to a case manager might be best fit for that person, right? But there's sometimes some icky system stuff that gets involved when people need higher levels of care. I know that sounds really muddy, but that's why it's a pitfall. It kind of happens sometimes. Consult when that happens to you. If you're like, I don't know what I'm doing, maybe it's because you're not supposed to be doing it. I put a lot of breaks in there for us not to take any breaks. Okay, how much time do we have left? We apparently have all the time in the world. 19 minutes. Would it be helpful to go through this piece, or do you want to stop and debrief about what we just talked about? Let me go on. Was that piece helpful? How to consult with other people? Okay. Y'all are getting tired, aren't you? I give too much flexibility. Maybe I should have been like, nah, y'all don't get what I'm gonna get and don't throw a fit. Wait, what do they say? You get what you get and you don't throw a fit? This is gonna be the most casual of all of your recordings all semester, Dr. I. Y'all should know when you ask me to come in. All right, y'all okay online? I don't know why I'm looking here. Y'all okay online, which is going over the next section too? Okay, they said yes. Oh, thumbs up. Share screen. So this is just like pro tips, like what I've experienced as a crisis clinical worker and kind of what I still do. Everything you're feeling is normal. Oh, ish, I don't know what to do. Or like, oh, all of it's fine. All of this is normal because we're human. And because sometimes crisis is hard. And because sometimes it is like, bruh, you're not gonna be able to jump off the harbor bridge. And sometimes it is, you are my 7th client of the day, and now I have to do a crisis screening. And it's Friday, and I have a date. Right, we're humans, or I have cramps, or, hey, we don't talk about cramps enough. Just saying, like all of these things, right, because we're human. Or I'm scared, or I'm worried, or I'm second guessing myself, or like, did I ask all the questions? All of this is fine. But, and Dr. I mentioned it earlier, know your stuff. It's all fine if you know your stuff. And know where you get stuck. I say this because of real life, okay? Know your resources, have your paperwork handy. Just have like a little folder, like this thing is all ratty already, but like I keep a little flowered folder just because it's different colors from my manila folders in my office, right? And this is just the one that lives in my office. I can grab it real quick. It's got my resources, it's got my things. It's not this particular one, but the one I keep in my office is like purple flowers. I know it sticks out like a sore thumb. I can grab it and go. I'm with a client, I'm online, my laptop at home, I changed the folder color to be purple. Open it, click, it's ready. I got all the stuff there. I know where it's at. Even though I've been doing this for a billion trillion years, I want to know that it's there. Because if I am having a craptastic day, or I'm tired, or I'm feeling a little crispy, or I'm sad, or the client before me was really hard, or I'm hungry, or I'm not feeling my best clinical self that day. My resources are there. Maybe I'm having countertransference. Who knows what? If I have my resources handy, because I know my stuff, it makes it manageable. And I take my time. If I have to clear my schedule, I clear my schedule. Because my job is going to make sure that you stay alive. I can't fit that in a 45-minute time slot. If I got to reschedule my next client, then I'll reschedule my next client. Granted, I work with a whole bunch of 10 other people, which is what terrifies me about private practice, like Sharon was saying. Like, what am I going to do? Like, if I'm private practice by myself, like, what do I do? Put this person on hold so I can like go call Bethany next and say like, sorry, I can't see you. But I have to, because I got to work with this person, right? So just clearing your schedule, being okay with that, taking your time, because it does take a long time, because sometimes there's silences and pauses, and there's a lot of questions to ask, and safety planning is not easy sometimes. Sometimes it takes a long time to figure out creative ways to, I don't know, sometimes people are more techie than me, but like how to save things and how to like make pictures and do stuff for them. Okay. When I try to rush, I feel more like I miss things. I feel more like I second guess myself. I spend more time on the documentation doing the notes. And then I'm like, I can't sleep well at night, personally. When you are documenting for crisis appointments, very, very clear. Be super duper duper clear. We also don't do a lot of training on documentation in the counseling program. We kind of tell you, like, your site will tell you how to do it, besides like a SOAP note and a DAP note kind of thing, which is site dependent for sure. Even if you go private, like you can just set it up the way you want your template to be set up. But a hospital will have a very different looking note than like a community service or MHID, like where you have to use like what 5 buzzwords or to trigger insurance and stuff. Like it's all different. However, I would recommend when working with persons with suicidal thoughts or ideations or plans, very clear. Client denies intent. Client has means, denies intent to use them. Wait, no, I have that backwards. Client denies means or intent. Client states, etc. Client states they have thoughts of dying, and client denies access to means. Simple, direct, very clear. During safety planning, information was provided regarding local resources, including 988, Trevor Foundation, etc. They can wait. Did I cover the lethality? Did I cover the method, the plan, the intent, the means, the access, the frequency? Did I document all the risk factors and protective factors? And I'm going to include language like client states their risk factors include access to mobile device of a wheelchair. Protective factors include willingness to engage in continued services. That sounds very clinical and dry, and usually I don't write that way. Oh yeah, I didn't even have a chance to say that in this session, but I'm like an RCT therapist, except for here. Right. So just documenting all of this stuff using direct language that's like this. Now y'all are like, oh my God. When you are documenting, always document what you're sending out and to who and when and how. If possible, in your charting records, make a copy of what you sent out. So if I sent a fax to Coastal Bend Wellness Foundation, copy that crap's going in my chart and it's attached to their records with a date time stamp thingy on there. And I'm documenting it. Writer faxed over, session note from today, indicating safety plan and level of risk, etc. Always make sure it's HIPAA compliant. Y'all don't even know in integrative care how many people lately don't have fax machines anymore and just want you to email stuff? And I'm like, well, is it a HIPAA compliant email? And it's like, no, it's frontdeskanna@gmail.com. Bruh, no. I'm not sending that to you. I'm not. You better call your office manager and figure out something that's HIPAA compliant for me to send you my documentation. I don't know why, anyway, let me stop. Let me parking lot myself. Making sure you send a copy of the consent form along with that documentation. And always sending the updated clinical documentation or progress note if you have a need to. So if you're sending somebody over to Bayview Behavioral Hospital, you're sending all of this to their intake department. You're sending them the release of information form. You're sending them your clinical progress note. If you have a face sheet or a demographic sheet, whatever they call it, depending on your setting, you're sending all that over to them. Half of y'all work at Bayview, but y'all don't do intake, right? Y'all work on the units at Bayview? On the unit, not in intake? Intake's where the fun happens. All right, I'm gonna run over. I didn't want to, but I'm gonna run over a little bit. All right, so some fun things, or not so fun things I've learned as a clinician. This one is embarrassing. When you're calling a support person, like when I call Beth over here to take Sharon, I'm gonna call, I'm working with, can I call you Beth? Yeah. Okay, I'm working with Beth as my client. And she's like, yes, my sister Sharon will take me to the hospital. And we call Sharon, we get her in here, and then I find out that Sharon is 16 years old. I'm like, oh my God, Sharon's not an adult. Sharon can't make no consenting decisions. How is Sharon gonna be responsible for driving Beth over to the hospital? Why did I not ask how old sister was? What am I doing? How do I was like, it was a mess. I had to try to find, and nobody else was available. It was a whole thing. But Beth was an adult. I just assumed that sister was an adult. I mean, there was a lot of potential legal ramifications for what if Sharon decided to just go home. A minor cannot have authority over an adult who is in a mental health crisis. Double check. It was a mess. Don't do that. Always double check when you're working with adults that the other person, support person, is an adult. Terrifies me now. Contact the hospital beforehand. So same scenario, except now Sharon is an adult. So Sharon is taking Beth over to the hospital. There's nothing worse. There's lots of things that are worse. It's very frustrating for Beth to go to the hospital for an intake assessment. And I know, Beth knows, Sharon knows. She knows active suicidal ideations. She knows she has a plan to get to the hospital for an assessment, and there's no beds. And there's nowhere for her to go. We only have 2 hospitals here in Corpus Christi locally. There's no bed at Oceans, there's no beds at Bayview. And so, yeah, they've admitted her, but now she has nowhere to go. So call the hospital beforehand. Do you have a bed for an adult 24-year-old female active suicidal ideation with a plan? And if they tell you no, then you can have a backup plan. Let me call Oceans. Let's call San Antonio. Do we need to have a different safety plan to get you to San Antonio? What else do we need to do? Right, that's a whole different training. Right, call the hospital beforehand. Because we only have, I'm gonna get it wrong, 38 beds in Corpus? No. We have very, very few adult inpatient psychiatric beds. Don't try to rush into another session. You need more, I need a restorative breath in between talking about topics, or when I've had my client with generalized anxiety disorder and the next client who has major depressive disorder recurrent. I just need a restorative breath and to go to the bathroom. When I'm working with somebody who has active suicidal ideations and we just spent an hour and a half on creating a new safety plan because the old one didn't work anymore because the boyfriend broke up with them, I need more than a minute. Uh-oh. Oh, yeah, they won't let me there. I need more than a restorative breath in the bathroom break. I may need a whole 30 minutes. Okay, so try not to rush into it, even though you think you can. Don't skip that lunch break to do notes. The notes are fine. You have 3,000 hours until you're independently licensed. The notes will be fine. Take the lunch break. And the last one. I don't just mean I have lost clients to suicide. And I have lost 2 that we think they died by suicide, but since they were indigent, then we didn't really do any follow-up and figure out what the causes of death were because they don't do autopsies. Get professional help. Consulting is not enough. Do you need to check in with a therapist? Do you need to take a week off? My dumb butt went back to work the next day. Don't do that. If you need to, take the time off. Because it hurts, because we do create rapport with them, because we do like them, because we do care about them, and because you do try to keep them alive. Right? And it sucks. It really does. And so what I try to do is like, I don't care if I just keep you alive today. I'm gonna keep you alive today. That's what I do. I tell them that all the time too. You can be mad at me tomorrow, but I'm gonna keep you alive today. I know that sounds really flippant, but it helps when I'm building the rapport with them. And it helps me rationalize because I have lost clients to suicide. But that is my job. That is my goal. And if you ever find yourself in that situation, and I hope to God you never do, I never wish that on anybody, get professional help. Don't be dumb like me. Pro tip. Don't just push through. So I know we're gonna go over. Why wouldn't somebody want help during suicidal episodes, thoughts, ideations? Huh? Their culture? Perceiving themselves as a burden? You're gonna throw my ass in the hospital. You're gonna throw my butt in the hospital. Systemic stuff, and generational stuff. The next slide says more specific culture stuff too. I'm finding this now to be overlapped on top of this. This is now becoming a little old. This is now 8 years, 6, wait, I can't do math. 8, okay. This is now older. I feel like this needs to be expanded and like to turn like a dial or something. And then this is much, much more prevalent now. And I only know this because I'm Gen X. My parents are boomers. I'm married to a millennial. I teach Gen Z. I mean, I'm Gen X. I'm married to a millennial. I work with a lot of Gen Z, and my kid is an alpha. And my parents are boomers. And none of us talk the same. None of us think about, my father will call me all the time. Do you still work with crazy people? What are you doing? Father. Old Mexican man. Because of this, like he just doesn't understand stuff and that. And then some of this, the understanding younger generations, and I'm older, right? So younger, no, I'm not boomer, yeah. Younger generations understanding mental health and understanding systems and things. We need to understand diversity and intersectionality. People know that counselors are mandated reporters. People are worried, they're scared that they're gonna be put in jail, that they're gonna go straight to the hospital. I have had people tell me straight out, no, I don't wanna answer those questions, you're gonna put me in the hospital. I just wanna know what's going on in your brain. I make no promises, no guarantees, honey. I just wanna know, do you wanna die? You know, and there's racialized medical trauma. What if you're gonna report me to CPS? I'm already in CPS. I can't catch another case, like, no. Police brutality, all of these things, right? Then there's cultural things. No, we don't talk about that in our family. I worked with some students, international students here at the university. And there is no language for suicide. There's literally no translation for suicide. You just killed yourself. There's no concept culturally for what that means in regards to dying. It was an accident, like you died by your own hand, but not like suicide like we think of mental health. I don't quite understand it because we do have that concept, right? So even assessing is hard, much as answering those questions. Okay. I'm looking. Just looking. Yeah. So these are some resources that I use a lot. A lot. MHID. Do y'all have MCOT in your phone? Y'all know what MCOT is? Y'all know what it does though? Not you, since you know what it is. That's cheating. Y'all know what it is? Okay, so Mobile Crisis Outreach Team is a unit of LMHA, the MHID. So they can come out and do assessments during the day. But that's also the number 2 kind of crisis here for Nueces County. So call it and they can help determine, does someone need to come out? Is it emergent, urgent, or does it need a follow-up? I think I have those levels right. Emergent means that someone needs to come out within the hour to do an assessment. Urgent is within 24 hours. And then there's like a follow-up process if it's not escalated that high. I think I have those timeframes right. Sounds about right. It's been a minute since I worked there. I had to use them for that. Every county in the state of Texas needs to be covered by whatever that version of MCOT is. There's something like 250 something counties in Texas. Nueces has their own because we're a pretty big county. Some of the outlying counties share one. But no matter where you are in Texas, because your license will be in Texas, you can call this one and get connected to any of them. So there should be some kind of response no matter where you are. The level of the response, the accuracy of the response may differ depending on rural location, time of night, that kind of thing. Remember, I don't lie to people, don't sugarcoat things. But I would still save the number anyway because they can still be helpful. We've had them come on campus to come help us do assessments. And they can help get people into MHID for crisis mental health services if needed. Bayview Behavioral Hospital. I send people there all the time, mostly for IOP. The women's IOP is really solid. But I also know the director of the women's IOP, and she's lovely. So that's why forming relationships is also good, because you know where people work and what they do. And I've known her for a minute, so she's super solid. Oceans Behavioral just started an IOP program. I think they only have 2 clinicians right now, 1 full-time and a part-time clinician, as the time of like today, as December 2nd. I don't know what they're, but they're growing. Ever since they tore down Memorial Hospital, they're trying to redo everything they're doing. So that's still a work in progress. I'm slamming y'all with resources that y'all get to have. These are the websites that you can have for the CSSRS. And you can get certified. Like there's like an additional 30-minute training that you can get. It's videos and stuff that you can watch to do that. And if you go to that main site, then you can find the different versions that we were talking about with the safety. I don't know why that one's not a link, but I'll fix it before I send it. American Foundation for Suicide Prevention always has all of the most, I like the research they have on there. I also like the stuff that they have on there because it's really good for use with families and support people, because they have lots and lots of good stuff on there that's good for lay people to read. So if I'm looking to share with a family or a support person, I might pull something from there, like a flyer or some like quick data or something, just to give them. Like I refer them to here. If you want a printable version of this little thing, that's where you find it. If you want where the safety plan went, it's there. Zero Suicide was an initiative that Texas had. I think it was like in 2013 or 14. They did a whole bunch of research and data. They collected all of this information it's still housed there, even though they're not doing any more active training and things. They still do a lot of data collection. It's out of UT, I think the Hog Foundation, if I'm not mistaken. And it's all housed there. Too much information, so don't fall down a rabbit hole. Be a little specific about what you want from there, because it's a lot. It's a whole lot. Deep breath. I'm only 5 minutes over. I cannot answer all the questions in the world because we can't know everything before we leave today. And I can give you all another 5-10 minutes maybe. Questions, comments, concerns, even if this was helpful or not helpful. Questions? People online too. Y'all also put them in the chat and then I'll read them.
I have more so of like a comment. So I was a case manager within MCOT at MHID previously. And like the crisis at like the MCOT center is kind of more so, I just want to make sure I clarified, it's more so like tailored to people who are our clientele that are already kind of in the mix with MHID. So unless you have like, I mean, unless it's like pressing and immediate, someone can come out there faster, but it's still a more delayed response versus calling like the National Suicide Prevention Hotline or calling in like assistance for immediate hospitalization. So I just wanted to make sure I clarified in case anybody called and expected something like immediate.
Yeah, no, that's good to clarify. Sometimes with working in interdisciplinary or integrated settings, y'all, differing information may differ depending on the organization that you're in, relationships that are being built, and kind of contacts that you have. So like, I've been in the field for a minute, so I can pull favors if I need to. Just putting that out there. I have cell phone number that I can text people like, yo, can you help me figure out if there's a bed somewhere? So always try to get information straight from the source. Don't take even my word for it. Does that make sense? I hope that makes sense. Do I stop recording now or do I wait? Okay. Pause.
Hi Sam, my name is Sydney and I'll be your counselor today.
Can you let us know if you hear the video, please?
Before we begin, I want to go over confidentiality with you.
Yes, we can hear.
Thank you.
All right. Hi Sam, my name is Sydney and I'll be your counselor today. Before we begin, I want to go over confidentiality with you. Whatever you say stays between us in this room. However, there may be times when I have to reach out to somebody. For example, if you tell me that you want to hurt yourself, somebody else, or talk about abuse against a child, a elderly person, or a person with a disability, I will have to report that as well. Also, if I receive a court subpoena, I do have to release the appropriate information. Do you have any questions about confidentiality?
No.
Then why don't you start by telling me what brings you to counseling?
I don't want to live anymore.
Okay, tell me more.
The other day, I get bullied at school. The other day, some kids beat me up in the bathroom and told me I'd be better off dead.
So what I'm hearing is you felt hopeless, and in your mind, killing yourself would be the only way you can experience relief.
Yeah.
Okay.
Okay, so just to clarify what some of the students here have said is that the tone seems to be kind of harsh, seems kind of robotic. Red flags are that I don't want to be here anymore, being closed off, and then of course, like the client directly answered the questions. Did I summarize everything else said? Flipping papers. Right. So paying attention to what the counselor's nonverbals are, just flipping through papers, like you're not making that direct eye contact. So what might have y'all done differently if you were the clinician so far? Okay. More of a physical engagement on the counselor's part? Right. Welcoming stance. And Tay said, you know, you hear that statement, put your papers down and show your client that they're the most important thing in the room at that moment. Uncross legs, lean forward. Nonverbal is very important. Okay, thank you.
In order to ensure your safety, I'm going to ask you some questions and you can answer as honestly as you can. I will be asking questions from the Columbia Suicide Severity Rating Scale. The purpose of these questions is to help me determine if you are in danger of hurting yourself or trying to kill yourself. Once we complete this assessment, we can create a plan together to help you stay safe. Is that okay with you?
Yeah.
Okay. Have you actually had any thoughts of killing yourself?
Yeah.
Okay, have you been thinking about how you might do this?
Yeah. I was thinking about taking my parents' whole bottle of pain medication.
Have you had these thoughts and some intention of acting on them?
Yeah.
Have you started to work out or already worked out details of how you might kill yourself?
Yeah, I was gonna take my parents' whole bottle of pain medication.
Did you intend to?
Okay. So now, what are some of the things that you are noticing? Yeah. Kind of like aggressive, like very like. Okay.
You know, also that like he seemed to make needed an option
Mm. Okay, okay. Anyone else? Yeah. Mm-hmm. 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 Yeah, yeah. And it's kind of like it communicates kind of like, are you not listening to me? Like what's going on? And then she keeps looking at the paper, right? Like that you already mentioned earlier. And then kind of like some of the questions are kind of like very fast paced, right? Like there's no like a lot of time to let him process, and there's not a lot of eye contact either. So what are some of the red flags from the client, from the things that he's saying, that you would want to take into consideration at this point? Okay, so if he has access to medication, okay. Access. Mm-hmm. Yeah. Anyone else? Maybe what kind of pills he's talking about? 'Cause I don't think they mentioned that. Pain pills? Okay. What kind of pain pills? Like, are we talking, like just over the counter, or are we talking, like, what are we talking about? Maybe also address that. Okay, we're gonna continue with a little bit more of the clip. Okay, someone in the chat is saying she's not attuned, connected with the client. Her voice is loud. Yes, definitely, Asia. She's being loud, she's being fast, she's just not doing a good job. Okay.
To carry out this plan?
Yes.
Have you ever done anything, started to do anything, or prepared to do anything to end your life?
I was going to, I was in the bathroom and I had the pain medication in my hand, and I sat there for over like an hour just thinking.
Was this within the last 3 months?
It was last night.
Okay. So based off the responses you gave me, it looks like you are highly considered at a high risk of suicide. What that means is that based on your answers, you are at high risk of attempting suicide. In order to ensure your safety, there are some steps we need to take. Do you remember when we first started talking and I told you that there were some limits of what I can do?
Mm-hmm.
Okay, so this falls under that category. We're going to work together to come up with a plan to keep you safe, and then we'll bring in your parent and let them know what's going on.
Okay.
First thing I need you to do is agree that as soon as you leave here, you will go to the emergency room.
Okay.
Okay. We have a lot of beef with this counselor. It's the general consensus of this room. But let's just talk about the turning point. Again, this is a simulation. It's very short. So it is like, let's take that into consideration, because I don't think anything would happen that way in session. And so would y'all be comfortable, or what are y'all's thoughts about turning it around right there? Like if you noticed how the counselor asked, like, remember our limits of confidentiality, and this falls under that. What are y'all's thoughts? Have y'all done that? / are you comfortable? More smooth. Yeah. We have a lot of students saying they've done it before, feel comfortable, it just needs to be smoother, a better transition. So how might y'all make that transition? Mhm. Right, so getting clarification from the client. So it was good that she said, like, let's refer back to the beginning when I said we had limits of confidentiality, but what were those limits of confidentiality? And let me restate them, and then we can move forward. Anybody in the chat? No, I don't see anybody. If you were ever in the situation, do you know what your site policy is regarding informing your supervisor? Pretty clear cut? Okay. And at what point would you involve the parent? Because this is supposed to be a child or adolescent. I mean, it's supposed to be an adolescent. I should have prefaced that. I apologize. But this is supposed to be an adolescent client. It's Sam, pretty much from the previous video. And so what point would y'all consider bringing the parent in?
When discussing the limits of confidentiality, I would have stated like, hey, remember when we spoke about the limits and when we bring in your parent and stuff like that?
Mhm.
This is gonna be one of those times. And then that kind of transitions into bringing the parent into the conversation.
Like right at this point? Okay, so, no, we got a response that, also it's important to inform client that the parent will be brought in as part, also as limits of confidentiality, like saying, hey, this is a point where I'm gonna have to bring, your parent in for support, because, can't sign documents as a minor. Who else? Offer prep. Okay. Yeah. So instead of saying, I'm gonna bring your parent in, it's like, okay, so this is what I'm gonna have to do. Remember, we talked about this. So let's talk about like some feelings, like what questions do you have before we bring mom in, like how this process is gonna go? Yeah. They get scared. Okay. Yeah. Yeah. So they shut down. You won't get a clear response. For sure. Thank you.
Good. Do you have any way of getting there?
My parent brought me here and they're in the waiting rooms.
Perfect. Before we let you go to the ER, we need to complete additional steps. Let's grab your parent and then bring them in here.
Okay.
Okay, I brought you in here because your child is considered a high risk of suicide. In order to keep them safe,
So that was a little bit short, but what changes are you maybe noticing in the client? Mhm. So tell me, like, be more specific. Like, if you were to put this in a note, like, what specifically are you seeing? Closed off. Okay. Okay. More protective. Okay. So if we were to like describe it, right, like in terms of like like talk to me body parts, like non-verbals, like what are we seeing? Minimal responses. Okay. Looking down. Mm-hmm. Okay. Limited eye contact. Yeah. Like he kind of like turned down, like he's not really looking up. What about what she said, like the counselor? I know we already we already described a lot of the bad things that she's done, but like in this before he went in for mom, what are the things can we note about her input? Mm-hmm. 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 Yeah.
You know what I mean?
Mm-hmm. Okay. Okay. So we already talked a little bit about how we would prep the situation for him, which she didn't do, right? She was like, okay, we're gonna bring her in, and then just open the door, bring her in. How would you have maybe debrief the parent, or like, I guess, bring the parent in specifically? Would you have gone out, like just bring her in? What would have been your process? Is there a process in your site for this? Yeah. As it did, right? Okay. Y- Yeah. So it's part of the prepping him, right? Like, so there's gonna be a lot of things that we're gonna be talking with mom. How can I assist you? You know, which parts would you feel more confident talking? Also, she doesn't really tell him what is it that we're telling mom, like other than you're high risk, you need to go to the hospital. Does the client have a good understanding about what that means yet, right? Like, so, um, what else would you have done differently in terms of like going to get mom? Or get mom? Yeah. Because the mom was like apparently like just right outside the door, right? Yeah. Mm-hmm. Yeah. Mm-hmm. Walk with me. Mm-hmm. Yeah. So why would we want to do that though? It's like that's the general consensus. What are we trying to avoid by leaving the kid or the client, sorry, in the room? Mm-hmm. Mm-hmm. Yeah. It's like abandoning him a little bit in terms of in that sense. Yeah. Yeah, there's a lot of things that we can have in our office that might be dangerous for them, and depending on how like what their specific situation is, and also it is kind of like abandoning. And in this specific scenario, like she's already a little bit like neglecting in terms of how she approaches things. So adding that is definitely a second level. Okay, so we're gonna do the last piece of the video.
We have to do some things prior to that. So first, I need you to sign this agreement stating that you will go take them to the emergency room as soon as you leave here today.
Okay.
All right. Next, we will need to come up with a plan, a safety plan. Basically, this is a plan to help you follow when you are having thoughts of killing yourself. By following this plan, you are more likely to stay safe and will not be at high risk of suicide. We will go through this and create this plan for you together.
Okay.
What are your warning signs that indicate you might be moving towards a crisis? This could be thoughts, images, moods, situations, or behaviors that you experience typically before you have thoughts of suicide.
It usually happens when I just think about what happened at school. I just keep hearing them say I'd be better off dead.
Any other warning signs you can think of?
No, not really.
What are some things that you can do to take your mind off of the problems that doesn't require contacting another person?
I like watching funny videos on my phone or just laying in my bed.
That's good. Those things seem like they really help you. If those things are not accessible to you, then what 3 people can you contact in order to help?
My parents, for sure. They're my biggest source of support. And then my best friend, they know I've been struggling, stressing out a lot. And then I guess maybe my English teacher, he's really cool and I trust him.
Okay. So go ahead and write down their names here. Let me jump this. Thank you. Let's see. Perfect. Now, what professionals or agencies do you know of, or if anything, that can contact you if you are in a crisis?
I'm not sure of any like around here.
Okay, that's no problem. I have a list of resources like the Mobile Crisis Outreach Team and the National Suicide Prevention Hotline that I can write down for you.
Okay.
Last thing, what can you do to make yourself in a safe environment?
I guess we could put the pain medication only where you know, and just so I don't know where it is.
It sounds like that would really help you. Is there anything else you would want to add or change to your safety plan?
I think we're good.
Okay, perfect. If you don't have any other questions, we can go ahead and bring your spouse in and let them know what's going on. When you can get to an emergency room and they can further help you. Do you have any other questions?
No, I just want them to get help, so thank you.
I understand. Go ahead and take this safety plan and then you can head to the ER.
Thank you.
Okay.
There you go.
But there's, I'm like, where are they having this session?
So it was a role play, right? We were
Yeah.
initially gonna have it in their house. And that was supposed to be like his room, but then
Okay.
they decided to make it their office. But the pills were still there, so it's like technically her office.
So she has her pills out.
Yeah, she has her pills.
It's a red flag. Yeah, yeah. I think this video is making it easy for y'all to like catch what's wrong and like what you could do differently. Do we need a restorative breath before we talk about this? I do, so I'm gonna. Because I did notice that there was no validation. Like, oh yeah, this is what I'm feeling. And she goes, okay, so like, what can we do about it? Okay. So let's just do the final processing questions here. As a counselor, what plans would you make to follow up with this client? Like if this was somebody you weren't seeing just like at a hospital setting, like this is actually your client you're gonna see.
Are they being admitted?
Yeah, so like for example, would you schedule another appointment? Would you check in with them at the ER because they're on their way technically to the hospital? So like what would you do to like follow up with them? Where did that third sound tray come from? Thank you.
I would probably check in with the emergency room to make sure they made it to the appointment.
Okay. Check in with emergency room. Okay, what else, y'all?
Well, then definitely schedule a call.
Schedule follow-up. Ooh. Making it a point to contact the guardian. Okay. Let's see, the chat says check in or go to the ER with them if my schedule allows / is flexible enough. Because they are minor, would checking in with guardian be okay? So I will say, like, what are y'all's thoughts about like, let's start with the first question about, the first response about going to the ER with the client. What are y'all's thoughts? So right here on the chat, we have check in or go to the ER with client if the schedule allows. What are y'all's thoughts about doing that as a clinician? You wouldn't go with them? No? Okay, so I'm gonna ask you why. Boundary? Okay, so it's like going back to personal boundaries of therapists and also probably what's appropriate at your site, because a lot of sites are different. The Wellness Foundation has the option of taking clients to ER. Beneficial from an integrative point. So depending on the client themselves and their comfortability and if they feel supported. Okay. Transportation issues, so clients might not have it, right? And again, it does depend on policies. So what about this last question? Because they're a minor, would checking in with guardian be okay? There's a consent, yeah? Yeah, would y'all do it? I'm getting nods from everybody in the room. So yeah, that sounds really appropriate. And Sharon, if you have any input, I'll just pass the mic here.
Obviously they're, well, not obviously, but like whoever is part of the file, then they do have that consent in a way. So yeah, that's what I personally would definitely do. About like going with them to the ER would probably not do it. Honestly, like being very, very honest, especially in private practice. But I would offer, and that's the other thing that I don't think she does in the video, right? Like maybe what would be the next follow-up that we could do? Like, is it okay for me to text you in an hour? Is it okay for me to call you tonight? Or what is, like, what is gonna be the next step? Because she kind of like just like, okay, so this is what you're supposed to do, bye. And then there's no kind of follow-up. And also if going with them to the hospital were to be an option, then because the whole transportation thing, like what if they would have to, wait for the bus, but you do have a car, so then it brings a lot of different things that you might or might not be, I guess, comfortable with. And also you might have more clients after them, right? So it's like a lot of different situations and points. But overall, what else would you all want to do with this specific client? So they left, and not what? What else would you have, would you want to add? I see Kendall typing. Mm-hmm. Yeah. I think that's where like it could become very handy to maybe call the hospital before they leave, right? Like when everyone's there in the office, like let's call the hospital to see what the waiting is, and then that way I can let you know already. And then if it takes more, then what can you take with you so that you can maybe do some coping in the moment. Um, yeah. And you want to prepare the parent for that, because then what if they leave like that and then they go and then the parent doesn't want to wait and then they end up just leaving, right? Then that's even more dangerous for the client, for your client, which is the minor, than actually preparing them. The other thing is that I don't in the video it's not like the part where like they explain to the kid what the experience is going to be if they've never been hospitalized before. I've had a handful of adolescents who come to me in the private practice as a follow-up or like aftercare, and they are so traumatized with the experience of being in the hospital that becomes like the main issue now. Like it's not even the suicide ideation anymore. Like after being in the hospital, it's such a traumatic experience. They see so many things, like they get a lot of intense care that they weren't ready for and that they weren't expecting it. And so this counselor, for example, she was like, well, you're high risk, you got to go to the hospital. And she doesn't even explain to him or to them what is it that they're gonna be going through. Yeah, like, am I staying? Am I just checking in? For those of you who are familiar with how the hospital setting works, how would you debrief this client to kind of like explaining more or less, they've never been hospitalized, how would you explain it to them? What can they expect? Mhm. Mhm. Yeah. Okay. Yeah, so those are a lot of steps that I can imagine the kid is not even like specifically, let's say this client. I don't think they might be aware that they're gonna get into scrubs, get like blood work, all these other assessments. Like that's a lot. So Kendall saying process and educating hospitalization procedures, yes, with family members and the client too. Yeah, because also the family member might not even know um what it entails. And giving psychoeducation about what to expect is really, really important. Yes, it's definitely really important. Like I said, the clients that I've had, that could have been avoided if they were debriefed first, at least, um, because it definitely becomes a very traumatic experience. Mhm. Yeah. Mhm. Yeah. Yeah, no, for sure. Yeah. Whenever I got this clients that I'm talking about, the very first one, I've never worked at a hospital either. I work at an outpatient. And so in my LPC associate group, I asked, because there's a lot of people who do, and I was like, can you all walk me through this? Because my client is saying that she's very traumatized, and we hadn't explored it, as in like we hadn't processed it, and she wasn't ready. But I was like so clueless as to like, can you walk me specifically through what happens to these kids whenever they go in? And they started kind of like debriefing me on how it works, at least in the Valley. And I was like, okay, that is a lot. Because it's not just what they have to go through, but also if they put them in rooms with other people, you know, like, and the things that they see or hear, also the medical professionals, how are they explaining things to them? So yeah, for sure, you as a clinician need to be very, very aware about your local sites, how they work. Yes. Yeah, but they do. Yeah. Hmm. Yeah, because then it's kind of like what she's doing in the video, which is kind of like, okay, I did my work here, then you go to that other place, and it's kind of like that's their problem now, which happens a lot with individuals who are going through suicide ideation. Like, okay, I did my work, it's someone else's problem now, and it really shouldn't be like that. Hmm. Yeah. Yeah. Hmm. It's a lot, yeah. Yeah, and then you have the other extreme of kids who have been through it for so much that they're so desensitized, right, to it. So yeah. Mm-hmm. Yeah. Mm, yeah, definitely. Well, thank you so much for everyone's input. We don't want to keep you all any longer than you need to be here. So, yeah, if you all don't have any questions or anything else for us, then you're all free to go. For everyone online, same thing. Thank you all for joining us. If you have any questions, just email us. We'll be seeing you around, okay? Bye.